Welcome to today's meeting of the Health Committee. Members of the public may like to follow London Assembly on social media and use the hashtag AssemblyHealth for this meeting. Please may I remind participants to silence devices. The main item on the agenda today is weight loss medication in London. However, we have a few short items of business first. Can I now ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chairman. No apologies for absence have been received. However, in accordance with the Standing Order 2.4, Assemblymember Ahmad will participate in the meeting virtually today.
Thanks, Diane. Moving on to declarations of interest, can we note the list of offices held by Assembly members? Thank you. Can I also ask members if they have any disclosable pecuniary interests in any specific items listed on today's agenda? Great, thank you. On to the minutes. Can we confirm the minutes of the meeting held on the 2nd of July 2025? Thank you. And summary list of actions. Can we note the completed and outstanding actions arising from previous meetings and the additional correspondence sent and received?
Noted.
Thank you. Action taken under delegated authority. Can we note the action taken by me as chair under delegated authority in consultation with party group lead members to agree the letter to Dr. Tom Coffey, OBE, on the committee's initial findings on men's mental health?
Noted.
Brilliant. Thank you. And response to committee outputs. Can I ask the committee to note the responses from the Mayor to our Dentistry and Oral Health in London report and the End of Life Care in London report?
Noted.
Brilliant. Thank you. Okay, so moving on to the main item of business today, weight loss medication in London. Can I extend the warmest of welcomes to our first panel of guests joining us to discuss this topic. Dr. Tamara Hibbert, Chair of the Newham Local Medical Committee, London-wide local medical committees, and Dorothea Norton from Homerton Healthcare NHS Foundation Trust in North East London. So I suppose if I could come perhaps to you first, Dr. Hibbert, and ask what are the main benefits and risks of weight loss medications?
So I think the main benefits are the cardiovascular, reduction in risk. We're certainly seeing an increase in obesity numbers, and we're seeing that, long-term conditions are adversely impacted by being overweight and obese. In my area of interest, which is diabetes, certainly many people with type 2 diabetes can improve their diabetes control, their sugars, their glycemic control, by losing weight. And whilst we have been really keen to ensure that the foundation is always around those lifestyle changes, so the dietary changes, moving more, being more physically active. We know for some patients that they need a little helping hand or a boost, and so not only do we see that by having some medication that can help them do that, it improves their sort of compliance and concordance with their medication, it also gives them that boost to continue to make those other changes in their lifestyle because they've had that quick fix sort of weight loss in the initial stages of starting the medication. So that's why we do it. We know that there's some really good studies that are showing not only benefits for diabetes but for heart disease, as I said, and for kidney disease. So in our area of North East London, those are priorities for us. So those are really the main benefits for us. When we look at sort of the things that we're not so sure about, obviously this is a new sort of medication to use for weight loss. We've had some experience of using it for diabetes, but rolling it out to a wider cohort of patients is obviously concerning because we may not see the benefits because we haven't got a metric like the HbA1c for diabetes to necessarily monitor. We've also got issues around supply of medication, so we would want to have a secure stock so that we can continue to prescribe the medication for patients that need it. But what we don't know at the moment is how many people will be able to take the medication, whether they'll have any side effects, and they can be some side effects that patients are unable to overcome. We are unsure of whether we will be able to sustain this supply for the long term because of the costs. And also we're not sure what to do when patients are ready to come off? What happens when they maintain their weight? Are we saying that this needs to be forever? And for some patients, that's something that they're not quite sure of. If we do need to stop or they have adverse side effects, what's the alternatives for those patients? So I think there's still a lot of questions, and I think that probably that's the biggest worry at the moment, because we just don't know what the future holds. Thank you.
Thank you. If I could just, as a quick follow-up, you mentioned side effects. Is there any predominant side effects or something that you've seen often? Is there a particular kind of additional condition that makes the side effect more prominent in some users?
So for our patients with diabetes, certainly if one of the side effects, because it acts on the gut, can be any of the GI upsets. So anything from vomiting to extreme nausea to diarrhea, constipation. And with any medication, there's always the rashes, sort of the intolerance because of the multitude of side effects. So we see that. Probably the major risk is something like pancreatitis that we would see, which is a concern. And then for patients with diabetes, because sometimes with a dramatic drop in their blood sugars, that can progress their diabetes eye disease, so retinopathy. So we really need to be cautious about making sure that those big swings in their sugars are not giving them irreparable eye damage. So I think that's my concern for my patient with diabetes. I think for patients who haven't got diabetes, again, it's an area that we need to investigate. And so as time goes on, I think we'll see more and more. But certainly for the patients in with my cohort who I've initiated, sometimes we see mineral deficiencies, because one of the things is that you can be overweight and be sort of malnourished, and I'm sure Dorothea will come into that a little bit more. So it's also about making sure that before we start that there isn't anything underlying that needs correcting. So we should be checking that there's no anemia, that B12 and their folate are all sort of within normal parameters, so that they then don't go and get sort of neuropathies or things that are reversible that we need to be looking out for. Thank you.
Thank you. And it sounds like you did a nice segue there for me to come to you, Dorothea, and ask from your perspective, what are the main benefits and risks?
Thank you. So I think this is a really exciting new advancement in the treatment of obesity, which should be understood as a chronic relapsing condition of really complex etiology that really sort of has a wide-ranging impact on patients' sort of physical well-being, as well as mental well-being, as well as financial well-being and social functioning. So I think this is a really important step in the direction of supporting these patients and giving treatment options. We know that currently lifestyle interventions, sort of specialist weight management services and the programs that are offered by them are of limited effectiveness in a clinical setting. So we know that there are often high dropout rates and limited sort of weight loss outcomes just from lifestyle intervention. And the reason for that is patient complexity, because those patients are presenting with the, often chronic pain, often sort of all these medical complexities which prevent them from being able to make the changes, as well as social deprivation, poverty, mental health complexity. So they're a very complex cohort of patients to support, and giving them this option, as Tamara mentioned, a quick, easy win at the beginning of their treatment can be really important in enabling them to then engage in physical activity and improve their chances of actually managing their health and wellness. I think another benefit is thinking about surgical cohorts. So thinking about patients where the limitation is of physical health and perhaps they have really poor mobility and are waiting for orthopedic interventions, but they can't undergo those procedures because of the risks around operating and their body weight. So it allows a pathway where patients can lose a significant enough amount of weight to undergo that procedure, which then improves their mobility and allows them a chance to go on and make those lifestyle changes. I think additionally, patients who might be at the sort of more extreme end of the body mass index, who require bariatric surgery, for those patients, reducing their initial weight to improve surgical risks is another really important aspect of using this medication and making this medication available. And Tamara's already sort of mentioned about the improvements in chronic health risk particularly around diabetes, but we know that even as little as 5% weight loss can really improve patients' cholesterol levels, blood pressure, HbA1c in terms of diabetes measures. And with these drugs, we're seeing sort of up to 20% weight loss, conferring these benefits for these patients. So in terms of the risks, I would like to sort of think of them in 4 different categories. One is nutritional, psychological, systemic, and then the sort of limitations of the drug. So from a nutritional perspective, there's the risk of obese sarcopenia. So unfortunately, the medication, whilst it reduces appetite, it does not influence the patient's choices in terms of nutrition. And so there is no guarantee that without appropriate and intensive wraparound care, patients will improve their dietary choices. And what we are seeing in clinical practice from patients who are accessing the drugs, perhaps privately without that wraparound care, often there is a deterioration in the nutritional adequacy of their diet. So they might not have an adequate protein intake, which can then lead to significant muscle loss and sort of longer term consequences for their wellness and functionality. So that is a major concern. And then as again Tamara alluded, there's malnutrition in terms of micronutrients. So this population is already at risk of deficiencies because of diet quality. And so deficiencies in terms of calcium, vitamin D, but also seeing things like zinc and copper, which is not something that is routinely tested for in the NHS because it's very expensive. So those deficiencies can go undetected in patients who have a poor dietary intake as a consequence of using GLP-1 without adequate supports in place. I think mentioned about side effects already, and low fiber intake, again, because of poor dietary choices can exacerbate that. And so we just don't know the long-term impact, for example, on gut health, which should be sort of considered. I would also say that clinically what we are seeing is that patients underreport the side effects. There's a real fear about the drug being withdrawn and the clinician who is prescribing sort of withdrawing the treatment if the patient reports pain or some of these side effects. So many patients retrospectively report that they have experienced difficulties, but they haven't told their clinician that this was happening because they didn't want to come off the drug. So I think that's a concern there as well. And just malabsorption of certain medications. So that there is a lack of evidence in the use of these drugs in populations, for example, with learning disabilities or significant mental health diagnoses, patients on antipsychotic medication where obesity is a real issue. And we don't know how the absorption of those medications would be impacted by the use of GLP-1. So there's some question marks there. Moving on to sort of the psychological risks. There is a real risk of dysregulated, disordered food intake in patients who are accessing GLP-1, again, without adequate wraparound care, adequate psychological assessment. Because the way the drug functions, it reduces appetite and the drive to eat, and hunger levels are minimized. We're talking about a patient population that struggled with yo-yo dieting and is desperate to lose that weight. So sometimes those patients absolutely stop eating because they can, and the rapid weight loss is exciting. It's not perceived as a cause for concern. And so again, without the support, the education, the support from allied healthcare professionals, these patients can just stop eating and have incredibly poor intakes, which in the short term will result in those sort of nutritional deficiencies and sarcopenia, but in the long term leads to dysregulated and potentially disordered eating habits. And thinking about a sort of exit strategy, again, if we're saying that the patient needs to be coming off this drug at some point, unless they develop sustainable eating habits, regulated, nutritionally well-balanced eating habits whilst they're on the drug, it's unlikely that the benefit of the weight loss will be maintained once they're not receiving that treatment. I think there is some evidence about patients who struggle with binge eating, improving their presentation. So it appears that GLP-1s reduce binge eating episodes. However, it does not address the underlying psychopathology of those patients. And we know that in obese populations, there's a high prevalence of trauma, there's a high prevalence of binge eating disorder, depression, and other mental health complexities. So again, whilst the medication alters someone's eating habits, perhaps for the better, perhaps for the worse, as I've outlined earlier, it does not address the psychological complexity that needs to be considered and could sort of impact on an ongoing basis and result in these disordered eating behaviours. And I think, again, just thinking about an exit strategy and a withdrawal, there needs to be a consideration of how long is the medication funded for patients on the NHS. And if it is not funded on an ongoing basis, what happens when the medication is withdrawn? So my understanding is studies indicate that most of the weight is regained within 2 years of stopping the medication. And obviously there is an impact on physical health, but there is also a psychological impact. So someone who's lost a considerable amount of weight, only to then experience regaining all of that with all of the sort of psychosocial impact as well as the physical health impact. What happens then? What is the support in place for these patients to manage that transition after they are no longer under the care of services to actively support them? Moving on to sort of systemic risks, I suppose there is a risk that as a society we fail to tackle the sort of obesogenic environment and the drivers of obesity because we now have a quick fix. So I think it's really important to acknowledge that prescribing this medication will not impact on childhood obesity rates, that we need to be still thinking about the wider determinants of health and obesity and not lose sight of that, whilst also making use of this medication for those populations that require it. I think it's also really important that we think about obesity care as a holistic pathway, and that the full extent of interventions is understood and the public understands the evidence around other options available. Obviously, there's been a lot in the media about this new treatment modality. It's a new approach, it's exciting, but we mustn't lose sight of the fact that actually bariatric surgery remains the most effective treatment for complex obesity. And for patients who have a high amount of weight to lose, perhaps body mass index sort of over 50, bariatric surgery is an excellent solution because we're looking at losing sort of 60 to 80% of excess weight, whereas with GLP-1 medication, we're talking about sort of up to 20%. So it's really important to understand that context and for our healthcare systems and healthcare professionals to be able to give that advice to patients so that they can make an informed choice about their treatment and what might be the most beneficial way to go forward for them. I think just in terms of limitations, I've already sort of made the point about limited research for vulnerable populations, such as those with learning disabilities, those with significant mental health diagnoses, I would also just like to point out that tirzepatide is a black triangle medication at the moment, so we need to monitor the sort of long-term impact and the side effects that are emerging in the context of the limitation that I've outlined before about patients being honest about those. Thank you.
Thanks, Dorothea. Just on a quick, perhaps a couple of follow-ups. With the surgery, would I be okay to term that as, say, that's gastroband kind of thing, right?
Yes, so gastric bypass surgery.
Okay. So if we're talking, say, gastroband surgery, what is the cost implication, I suppose, to the NHS as opposed to prescribing weight loss medication? You just said there that the gastroband, as it were, is going to be the most effective treatment. Is there naturally going to be a move towards not prescribing that surgery where there's weight loss? Is that going to be a saving? Is the saving a good thing? Is the saving a bad thing because perhaps we're not giving the right treatment?
I think that's an interesting question. I think there are studies out there that looked at the cost effectiveness of the different treatment options, and I can't quote you the exact figures, but from memory, those studies suggest that bariatric surgery is more cost effective than GLP-1 prescribing in the long term. So I think it's really important that commissioning of bariatric procedures it remains available as an option and is considered treatment for patients with the complexity that's presented in the NICE guidelines for referring for bariatrics. I think having said that, not everyone wants to have bariatric surgery. Not everyone is suitable for bariatric surgery. And I think it's important that patients are given choice around this. So I think cost absolutely needs to be a consideration, and the NHS needs to deliver value for money. But patient choice should also be factored into that as well. So I think it just needs to be a holistic picture that looks at treatment options, but also looks at the wraparound care. And we'll come on to talk about that. I think with that wraparound care, we're going to be very limited.
Yeah, thank you. It was really interesting and surprising. Dr. Hibbert, sorry.
So I think cost is always a really interesting thing because it's very difficult to quantify each segment. So what we've heard is that you need a specialist dietetic service, you need that wraparound care. But what we haven't looked at is how many appointments will that take? And when we're trying to do a head-to-head study about cost, that's very difficult. So I think, as Dorothea said, we need to make sure that we have patient choice at the centre of this, but bearing in mind that everyone is an individual, the medication will impact them in different ways, and therefore that in itself may mean that they need more appointments for something else that we sort of unravel. So the cost argument is really difficult for us as clinicians to discuss, but I think that for any of our conversations, we have to make sure that we have a significant buffer to make sure that we can cover the costs and there aren't any sort of gaps in service. And we need to make sure that we have bariatric surgery as an option because sometimes we need 2, not 1 interventions for individual patients. Thank you.
Thanks. And that's really interesting. And just to capture what I think both of you are saying, is that we wouldn't want to see a reduction in provision of bariatric gastroband surgery because of the prominence of weight loss medication. And that's perhaps something that we need to be aware of into the future, if that's correct. And just one other follow-up from me, Dorothea, you said something about, I think it's really interesting, on the systemic issues not being solved. Is there perhaps an argument that medically induced or not, it's changing behaviours perhaps of parents, and as such, that might have an impact on childhood obesity as well? Say if the parents are now having smaller portions, less binge eating, informing those habits, may that have a wider effect?
I think it makes some assumptions, your question, right? Because the assumption you're making is that the parents are making different choices, not just reducing portion size, but improve the nutritional adequacy and balance of the family's diet. And unfortunately, that's not necessarily what we're seeing in practice. So I suppose at the moment, the patients that are coming through are generally accessing NHS specialist weight management services, but are accessing GLP-1s outside of that privately. Largely, they have not engaged with the sort of self-guided wraparound care that some of those private companies offer. And so what we're seeing is that they don't necessarily make better nutritional choices. So I think anecdotally, I've had patients who would report that because they can get away with eating very small amounts, they might have sweets or chocolate instead of a main meal because they still really enjoy those foods. So the fact that those foods are, very much available in our environment, they will want to have those foods, but they will skip having a balanced meal because they can. So I think we mustn't make the assumption that just because parents are using GLP-1s, there will be a better balanced diet provided for the family. I would also say that we would need to work with the food and industry on portion sizes because the portion sizes are what they are. And essentially, patients might be buying exactly the same foods, but are eating maybe half or a quarter of it, but they will be the same sort of foods that are on offer rather than sort of anything different. So it might be that in the long run, there is a shift towards a reduction in portion size, but of course, we'd have to work with the food industry to make sure that that happens, as opposed to just increased food waste because of patients not eating the full amount.
Thanks. Assembly Member Boff.
That's really astonishing what you said about bariatric surgery and the cost effectiveness of that. And at some point, I don't know if it's possible our researchers could could look at, you know, having a tariff of what the NHS tariff is for these different treatments. Are you saying that, just to be clear in my mind, that the bariatric surgery is probably cheaper if you take into account the whole wraparound services of the drug? Because with my layman's mind, I thought a pill can't be, cannot be more expensive than bariatric surgery.
So I think the way the cost is worked out is relatively complicated because it sort of looks at a patient's trajectory across their sort of lifespan. And so if you think bariatric surgery have X cost, but it reduces a patient's excess weight by, let's say, 70%, and even if the patient was to regain that weight 2 years later, it sets them on a considerably lower trajectory, and so they will hit key markers that will have a cost implication for the NHS at the sort of later point in life compared to the drug. So I think there is a consideration for the sort of upfront cost of the drug versus the surgery, but there's also a consideration for the sort of the rest of their care based on a lower weight trajectory that's been set. So, but I think that's quite a complex area that probably could do with sort of looking at the exact research.
Thank you, Dr. Hibbert.
So you said a pill. Okay. So I think that sort of undermines the range. So we have some
I
pills,
get
but
that.
we also
I
have
was
injections.
being a little flippant.
No.
It's
yes.
because you need that wraparound.
You need the wraparound. So the other issue we have here is that actually we need to teach patients how to administer the medication. And there are the consumables like the needles, how we dispose of the needles, how we dispose of the devices. So those costs have to also be built in. But if we look at how long it actually takes to teach a patient how to use the medication safely, use the different devices, that takes up a significant amount of clinical time. And there are a number of appointments that then need to be followed up. We need to make sure that we've checked the side effects. So all of those appointments need to be factored into the overall cost. So whilst we might have some patients who initially, maybe for that first 12 months, will go to specialist weight management service, we then have that ongoing cost of making sure that we are reviewing these patients. And some will need more reviews than others. So we have to factor that into the overall costs as well. And I think when we come to the bariatric surgery, we're not saying that it's the surgery and finish. We do still need to follow those patients up. But as Dorothea says, that we're hoping that we will get more people more economically active. And so that cost also needs to be sort of factored in as an offshot. Yeah.
Thank you for that clarification. Thank you, Chair.
Thank you. If we could come on to perhaps some more London-specific concerns. Could you say a little bit more about the rollout of medicine across London, and also what is the demand like in London in comparison to the rest of the country? Who wants to start?
So it's very difficult. If we look at the headlines, I think that there has been an absolutely explosion of, sort of articles. Every time you sort of look at your phone, there's an article about this. So it is increasing patients' expectations, not only that we will be able to prescribe it, but that it's that panacea for everything. And so that's important. So I think there's a lot of interest. So what that's meant is that as soon as the article hit the news, patients were contacting their GP surgeries. We were inundated with requests to start medication. And when we look at the first cohort that NICE sort of recommended, it was about 220,000 patients across England. When we look at North East London, of the patients that we think would be eligible, it was about 150. So there is a huge discrepancy in what's currently sort of the first cohort, and we heard from NICE that it might take 12 years for us to sort of roll it out. And patients don't see that. What they see is that there's a medication and that as GPs or other clinicians, we are not prescribing it to them. And so we do have significant demand, and sometimes that demand has been quite challenging, especially as there were some patients who, before sort of the stricter guidance came in, because there was a lack of another GLP-1, we were starting to transfer some patients over to tirzepatide. So I had a diabetes group consultation the other day where I had a patient who I had managed to start, and I had a patient who was sitting directly beside them who I had to say, no, I can't initiate you because actually the guidance has now changed. So we have to have those, sort of real conversations. But if we look across London, I think the majority of areas haven't got a safe clinical pathway in place. I think we're all sort of scrambling to try and get something together.
Sorry, could I just be a safe clinical pathway, meaning a GP,
whether it be GP prescribing or whether it be that specialist weight management. Whether it be that specialist weight management service, because I think, as you've heard, that this isn't just about prescribing. There needs to be a lot of input that doesn't only come from a clinician prescribing, but dietitians, psychology, as well as our clinical pharmacists, for example. So it's a real MDT. It's a team approach. So we need to build those services, because at the moment there is still a significant wait for a dietetic service. If we look in North East London, we have very limited capacity. So in order to add this, we'll have to, recruit more staff, and, the workforce issues and the funding for those roles needs to be secure, and not sort of just for a pilot where it's a year, and then what do we do with those people who are, maybe left jobs or have trained up and we can't, continue that service. So we need to build that safe clinical pathway, and we need to understand, from an education perspective, which patients would be appropriate for which treatment. So that takes time for the clinicians to learn that, because this is a new drug for many people. So all of that needs to be considered when we say we're building a safe clinical pathway. But if we look across most of London, we haven't got a pathway in place yet. We're piloting, and what that means is that when we have this expectation from patients, that we still haven't got anything that we can refer them into on the NHS, that we have tested and we know is effective, both cost effective and also sort of showing us the clinical outcomes that we're trying to achieve.
I suppose I can only really echo what Tamara said. I think the lack of consistency across London and probably across England and the UK is the sort of experience that is reported back by colleagues and by patients. So there is a considerable postcode lottery. Even sort of if we step away from GLP-1s, even if we just look at sort of the commissioning of specialist weight management services, we know that sort of 40-50% of areas commission a service and others do not. So I think often sort of obesity management and specialist weight management has been deprioritized as a sort of commissioning area, which needs to be considered. And I think that lack of sort of fairness, the way patients see it, is really apparent across areas. But as Tamara was saying, even within the same area, some patients were able to sort of get started on the drugs and others were not. So I think we are seeing a huge increase in referrals with patients wanting the medication. I think it would be really good to try and pull together the data. So my understanding is that all the different ICBs are doing some modelling and doing some work on demand and capacity, and thinking about what those clinical pathways could look like, should look like. And it would be really helpful to sort of have some degree of consistency across London, so that patients can get away from the sort of postcode lottery of this. But unfortunately, the demand is very, very high. And as Tamara said, patient expectations have really shifted. And patients are really unhappy. So I think it's becoming quite a difficult sort of clinical environment for our teams to work in, because there is such a gap between what patients understand from media reports of what is available and what they should be entitled to what is actually possible and what they are being given on the NHS. So I think it would be really important to sort of try and bridge that gap and sort of educate patients on the sort of realities of what is happening in the NHS. But I think that would necessitate a consistent approach across the different areas, so that can be communicated to the patients.
So it seems like the gap between obviously where private access through the NHS is actually really, really wide. I didn't quite realise. So in terms of obviously people going through an NHS pathway, Does that mean most people are disappointed at the moment? They are perhaps calling GPs and there's a level of demand, and that is, most people are not having that demand met?
So I would just say, again, anecdotally and clinically, what we're seeing in our weight management services, that patient satisfaction with the service has gone down. And the intervention hasn't changed, so we've generally had very good ratings, and patients, receive our intervention really positively. But I think patients' expectations have changed. I think we are seeing that there are many patients who are self-funding on the GLP-1s, so that difference, that inequality between patients who can and can't afford is growing. And yes, I think those are the patients obviously who are eligible to a tier 3 style intervention, but there's obviously others as well who don't access our services, and the gap between those who can afford it and those who can't afford it is growing.
Thanks. So ultimately, the weight loss medication across the NHS is seen as something to reduce pressure over the lifetime. It sounds like in the short term now, it's creating more pressure in certain areas, and obviously the long-term benefits will take a while to realise. Is that the case at the moment? Is this causing more pressure? Have I read that right?
You've definitely read that right. It's causing more pressure because we have a lot more patients who are asking whether they are eligible. So those patients wouldn't necessarily have come forward before, or it's an additional, oh, by the way, while I'm here, doctor, can I just ask? So that increases the appointment time, but it's also the satisfaction. And as far as, the relationship that we have with our patients, it's very difficult to say no to somebody when you know that actually it would be beneficial. It's very difficult to hear when patients say that they just can't afford it, or they're concerned that they can only afford it for 6 months, and then what? Can you then, please, doctor, prescribe it on the NHS? So there is also that sort of moral dilemma that we're having to deal with day by day, because we know we're prescribing it for some and not others, so there's that inequality. But I think also with the concerns with the pricing of some of the medication, there was a slightly cheaper deal, and then now that the prices may go up, we've certainly had even more patients who've maybe gone to a private provider, can no longer afford that, and are asking us, is there any way? So not only are we having the patients who are asking, can we start it? We've got patients who have gone to a private provider and then are coming back and because they can no longer afford it. And then I think the other dilemma is that as we said, and we spoke about, sort of patients and their families, that sometimes this is what should I pay for? So yes, we've got patients who can afford it, but we've got a lot of people who are making sort of choices around, I need to lose weight because I need to go to work. Therefore, I'm not going to necessarily buy such healthy food, or I might not fix the leaky tap. So we have patients who are saying that all of these other financial constraints are making it very difficult for them to sustain the medication when we've seen the benefits. Can we not then continue to prescribe it for them? So we're having this sort of conversation, quite frequently. And, I wouldn't have thought about that before, but that is what's sort of coming into the conversations and in our consultations with patients now. So we're very much seeing that need.
Assembly Member Wilson.
I think my questions largely follow on from Assembly Member Best's question, but looking at the rollout of Mounjaro so far and in GP surgeries, and obviously with our London interest in particular, just a little bit more about how effective that rollout has been, both in terms of accessibility, which I think we've covered a little bit already, but also in the actual results for individual patients. The experience that you've had dealing with patients, prescribing these things, has it really shown an immeasurable uplift or improvement to their conditions?
Yes, so if I look at some of my patients with diabetes, within 6 months of them being on the medication, I've seen HbA1cs that have gone from 65, sort of all the way down to about 48 or under. So the medication for some patients is really effective. And I've got some patients who've lost around 20 kilos of weight. Obviously, it depends on their starting point. But we've seen sort of a 5 or 10% reduction in the BMI. So we know for some patients it is effective. What's interesting is, though, that they need that at different doses. So I have some really great results, and we never get beyond the 5 milligram dose. I've got other patients who have pressured and moved along up to the maximum of 15 milligrams, and they're still not really losing the amount of weight that we would expect, and they haven't necessarily had a huge improvement in their HbA1c. And I think some of that is down to the fact that they haven't necessarily taken on board that they do need to eat and move differently. As Dorothea said, you know, if you don't have that education around the lifestyle changes, as much as we try and do that, then it's quite difficult to see those benefits. But that's in a cohort of patient with diabetes. For weight management, we probably are not prescribing, you know, sort of consistently across certainly my practice. And in North East London, we haven't got pathways yet. So we have some GPs who have been trained and aware of how to use the medication because of patients with diabetes. But for weight management, as I said, we haven't got a safe clinical pathway as yet, so that hasn't really happened. But looking in some other areas, if we look at South West London, you know, looking at that ICB, the figures I have at the moment are that about 45 patients have been commenced on treatment. 3 were unsuitable and 10 declined. So that we're talking about very small numbers of patients, you know, sort of in very large areas of London. And I think that, you know, we've got quite strict, you know, sort of eligibility criteria, and so our numbers will be small. But I think that's really important for us to have the learning and to understand, you know, what the needs of the patients are, and what wraparound services that we need, so that we can build something that is safe and sustainable. So I think the point is that I just don't think that the ICBs have the funding, and certainly I don't think that the clinical spaces that we would, you know, sort of expect to commence this medication, whether it be GP surgeries or in the specialist weight management services, we just don't have the workforce or the capacity to see even more patients. So all of that needs to be taken into consideration as to, I think, why we haven't had the rollout that we would like, but we do still need to look at the cohorts that sort of NICE said would be kind of rolled out over a number of years. So time is an important factor here as well. Thank you.
The next question, I think you've already pretty much said the answer, which is asking, yeah, are GP practices sufficiently resourced to handle the increase in, you know, appointments and development? I think clearly what you've said is no. So is this something that pharmacies can do more to help with, to take some of that pressure off GP surgeries?
So I think our pharmacy colleagues have a place to support some of this, you know, sort of rollout, but I don't think that they are going to be able to absorb all the extra demand. I think there's enough for them to be doing. I'm sure that, you know, when we talk about sort of hypertension and we talk about our flu campaigns, our pharmacy colleagues work very closely with us, and I think that's important. But I think for all of the reasons that we mentioned earlier around it not just being a medication, it's not just about the prescribing or even learning how to inject or to, you know, how to take your medication. It's about that ongoing support and awareness of what's in a patient's clinical record, but also taking into consideration all of the wider determinants of health, whether it be mental health, whether it be learning disabilities, whether it be the health literacy, whether it be the financial situation. So I don't think that our pharmacy colleagues would be able to absorb that. I think that this still needs to stay with specialist services, just because it is a very new pathway, and we need to make sure that anything we're doing is clinically safe and effective. Thank you.
And then just finally, and again, something that Emma's already kind of alluded to, but the sort of balance between increased pressure and resource now, but ultimately, hopefully, kind of long-term saving. So in the patients that you are working with, and I appreciate, again, it's still sort of early days, but are you seeing less pressure on the other conditions that they would otherwise have developed or exacerbated if they weren't doing this? And are you confident that ultimately a more effective rollout of this and a more accessible rollout of this will prevent bigger pressures further down the line?
So I think it's really difficult to say because we just haven't had that longitudinal sort of data and experiences yet. But if we look at something like sleep apnea, if patients lose a significant amount of weight, then there is an improvement in the fact that they may not need to use CPAP anymore. And so we can project that. That's our, that's our vision board. That's where we want to go. But I don't think that we have the evidence to support that as yet because the numbers are so small. So I think it's really important to not get ahead of ourselves. We need to make sure that everything that we're doing is evidence-based. And I don't think that we have the evidence base as yet.
Sorry, Alex, can I come in on that as well? So I think just going back to your previous question about the pharmacy provision, I think my understanding from the interim commissioning guidance from NHS England around the primary care rollout is that the funding for the wraparound care will remain central. And so that is an area where it's not clear how the rollout should work in terms of the prescribing sort of moving into primary care, potentially pharmacists supporting it, but then who's going to do the wraparound care? Because it doesn't sound like the funding is going to be coming down to the ICBs to be able to provide that. And we can only sort of imagine right now that presumably there will be a central sort of possibly digital option for patients to access the wraparound care, which may or may not be suitable for many of the sort of inner city London populations that have difficulties around digital access. And again, we can talk about that a little bit more around the wraparound care. But I think that's one of the sort of barriers that I can see around the rollout. So when I speak to primary care colleagues and PCN dietitians, the concerns they are raising from primary care is that there isn't the capacity to take on those patients and sort of manage the prescribing, but also there's this question mark of who's going to be providing the support around it. And then just sort of thinking about your second question, I think around the sort of potential benefits. My understanding is that most of the ICBs are doing some degree of modelling of the sort of return on investment, if you like, of funding particular cohorts to access the medication. And I think it's really important that we're looking at that return on investment sort of in the short term, but also that modelling is comprehensive and complex enough to take into account all the sort of areas that obesity potentially impacts on, so economic inactivity, as well as the sort of physical health conditions. And I think sometimes what happens is there are particular conditions where it's easy to measure the impact, and we sort of limit the analysis and limit the modelling to those conditions and forget about the sort of wider areas. So I think it's really important that there is robust modelling that looks at the cost of not funding particular populations, particularly in mind with the sort of 10-year plan that's focused on prevention. I'm mindful that the sort of phased rollout doesn't talk about patients who don't have any medical conditions who are yet to develop it, which doesn't seem to align. So I think it's really important that we sort of have a considered discussion, and any sort of modelling and analysis is complex enough to take into account all the issues.
Obviously, the more we do, the more data we get, the better we'll understand it, and hopefully they'll move forward. Thank you very much.
Thank you. Assembly Member Rani.
Thank you, Chair. I'm going to start with the point that you ended with there about patients that are perhaps ineligible at the moment that could benefit, and probably turn to you as a GP, Dr. Hibbert, just about prescribing. So when you're faced with a patient where it's clear that the trajectory is going in a certain way, would you like to have the option to be able to prescribe as an option?
I think as, sort of family doctors, and, we've built a significant relationship with most of our patients. And yes, I think we're well placed to have those conversations. And it might be that as I can give options, there are a suite of options that this is what you could consider. But for me, it's also about making sure that I've got those specialist services that I can refer that patient onto. So there's one part of it about, yes, I'd like to be able to have the discussion, and as a GP with an interest, then yes, I would be able to, I'd be very keen to initiate the medication as long as there was the appropriate funding and wraparound care available, so that I could, make sure that patient was safe and the medication sustainable. Yes.
Okay. And just going back to the issue that you've mentioned already about the 12-year sort of time frame really for that is projected at the moment for all patients to be at accessing that are eligible. Do you feel that that rollout or the movement towards access and availability should be much quicker?
It's an interesting question, isn't it? Because I've just said that we need time to, develop some evidence and to train everyone up. I think we could do that faster, but obviously the major delay is funding and workforce capacity. So if we could have the appropriate funding, and if we had a little bit of headspace for for clinicians and the teams to sort of build these pathways, I think yes, it makes sense to shift this into very much a prevention space. I think it will in the future help, but this is a part of that. And all of the other sort of psychological inputs that we've discussed, all of the external factors, so the food economy, the food industry, getting the sort of the changes there also needs to go in tandem with it, or else I think we risk that we have some really great medications that work for some people who are motivated, and others that in the end it just hasn't worked, and we don't actually move as a population, as a society, forward with really tackling our obesity crisis.
So just so that I'm clear, so the example, let's say, of a patient who is taking the medication as prescribed, if they are making no changes in terms of their lifestyle and the way what they're eating or exercise habits, what do you see? What's the impact on those type of patients that you see on a day-to-day basis?
So the ones that don't make the lifestyle changes are the ones that are usually rapidly, progressing through the dosage. But it's also about making sure that they are developing good eating habits, sort of they've got that education so that they're not developing the other sort of deficiencies that we mentioned earlier. And that they're building muscle mass, which is really important for metabolizing your sugars and utilizing your sugars. So we don't want people to lose weight and to become unhealthier for it. So I think it's really important that as part of this, there needs to be side by side to the prescribing, a real push to educate patients around the dietary changes that need to be made so that they reduce their risk of complications moving forward.
Okay, and same question to you, Dorothea, really on the pace of rollout.
I mean, again, I can only really echo what Tamara said. I think the resources and the workforce development is sort of the limiting factor. And so if those things can be put in place, then I think it would be great if we could move faster. But I think it's really important that there is a sort of systemic plan on how to tackle all the kind of wider determinants, and that we think about what an integrated obesity care pathway looks like that holistically addresses patient needs rather than the sort of idea of we're rolling out a pill that patients will pop.
Thank you. Thank you, Chair.
Sorry, actually, can I just, on your last question as well, I think that there is data from the drug companies about the effectiveness of their drugs. So I don't want to misquote it, but I think there's about sort of 20% of patients where the drug is not effective. So we know that it's not a magic pill for everybody. It's great and it's very effective for the majority of patients, but we know that it doesn't work for everybody, even sort of under clinical trial conditions. So I think that needs to be borne in mind, and then additionally, those patients who don't make those changes will get suboptimal outcomes as well.
Thank you. We're going to move to Assembly Member Ahmed, who's online, so you have to look to the big screen.
Thank you, Chair. Good morning, panel. If we could go back to the issue of the exacerbation of inequality, what I'd like to know is what is happening to patients who are on the waiting list that you're talking about and who can't privately access the medication because of cost and it's prohibitive for them. What's happening to them whilst they're waiting? I'd like to know, you talked about lifestyle changes, you talked about that wraparound care, and also in London, I mean, I don't need to tell you, particularly looking at diabetes, that diabetes particularly is prevalent amongst certain community groups within the population. And I really would like to know what's happening if those groups and if you know, people who can't afford to access privately this medication and they're just having to wait, what's happening during that time?
I can start. So I think the reality is that the gap between those people who can't afford it and those people who can afford it is widening. So whilst we have a lot of talk about reducing inequalities in health in all our policies, in all our sort of future plans, the reality in this particular domain is the opposite. So I work with a lot of ethnically diverse populations in East London, and the reality is that we are seeing those patients not being able to access those provisions, getting more and more frustrated and disheartened. I think that there are layers of disadvantage. So those patients with the language barrier, or as I said, sort of significant mental health complexity or learning disabilities, who are perhaps either excluded from specialist weight management services or are requiring one-to-one treatment, as opposed to being able to sort of engage in group-based intervention in specialist weight management services, are already experiencing much longer waiting times to access their care for the sort of specialist intervention around dietary advice, exercise or psychology. And in addition, of course, they are also struggling to afford the care. So from my experience, it's a widening gap between those who can and those who can't afford it, and a sort of associated deterioration in health.
Okay, but what's happening to that cohort of patients in terms of, I mean, if you've acknowledged that there is, an exacerbation of the inequalities, but what support will they be receiving during that time that they're waiting? Is there anything? Are they being directed or signposted to any services?
Is it on? Yeah, sorry. So before we had this medication, we had patients who were on waiting lists for operations or who, would benefit from weight loss. And we do have some other programs that we can refer into. So there's the digital weight management if they've got hypertension or diabetes. And many areas do try and have a tier 2 weight management service. And obviously we would, as GPs, try and give them as much support and guidance using our practice team. Our nurses are particularly useful at having sort of conversations with our patients and supporting them while they're waiting for that next step. But I think for us it's about making sure that we have equity to access to the current offers that are available. So if patients are newly diagnosed with type 2 diabetes, then we had the type 2 diabetes remission pathway, which was, sort of lauded as the soups and shakes, and we were diet, and we were in a similar situation where the media got hold of that, and then there was that influx to GP surgeries around this. So I think it's about making sure that we're having those discussions with patients about what their individual needs are, and then as the team that knows them very well, trying to find an alternative whilst we're waiting. And I think that what we've said from the outset is that it's really important that we value the specialist dietetic services, and patients will have different needs, and what we need to be able to do is to be flexible enough to match the need of the patient with the appropriate clinician or team that can support them whilst they're waiting. And I think that we work really hard at trying to do that within the limited capacity that we have. But I think it's fair to say that, unfairly, there will be patients that will fall through the gaps. And what we're trying to do is to make sure that by coming here today, having these conversations, is that we help fill those. Thank you.
Okay, great. Thank you very much. Thank you, Chair.
Sorry, can I come back on that as well? So currently the sort of NHS England Interim Commissioner guidelines state that local systems should continue to consider weight management services for specific populations disproportionately affected by excess weight and groups which experience significant barriers to equitable access of services. So there is that statement in there. However, I would say that the sort of 3-year, the phased rollout and the priority patients identified for the first 3 years are really sort of mainly qualified by their body mass index and by their comorbidities. So, which then sort of leaves that risk that those patients who don't fall into that criteria but struggle with inequitable access to healthcare and worse outcomes will be missed. So I would urge this committee to use its influence to change that.
Thank you. Assemblymember Harani.
Thank you, Chair. Just looking at the prescription data, so it suggests at the moment, and we're looking at sort of the picture in London, that London's ICBs prescribe far lower compared to the national average, apart from one ICB in London, which is North West London, which comes in the top 20. The rest are considerably lower than the national average. Why do you think this might be? Maybe turning to you, Dorothy, first.
So I think anecdotally, again, what I hear from colleagues is that reluctance to start prescribing in primary care because of the lack of an established pathway and resources allocated to support the prescribing itself, but also the sort of wraparound care that's required for these patients. So that's my understanding for the barriers.
Yes, I have to agree with that. I think that we haven't got an enhanced service. We do have sort of the weight management service that's part of the DARES that, we have a clear pathway about what we should be doing with that. But when it comes to prescribing of the medications and the importance of having the access to the specialist weight management services, we just don't have that built in London as yet. And so I think a lot of people are reluctant to initiate a medication where they're still learning about sort of the potential benefits and side effects. But we know that what's very important for us is that we want to get it right the first time. It's really important that sort of principle. And we have patients who have probably language barrier issues. And so what we want to make sure is that whenever we initiate a medication, that we can really have a conversation with patients so that they can make an informed decision and give us consent. So unless you're 100% sure that that patient understands the pros and cons of starting the medication or not starting the medication, it can make it a little bit more difficult to feel confident, I think, in rolling that out. And again, we're waiting for sort of a little bit more real world experience and data to show us what this is like for our population. And a lot of the research that's carried out by drug companies do not actually cover the wide variety of ethnic diversity that we have in London. And so, again, it's very important to make sure that we can feel confident when we're having those sort of consultations with patients, that actually we can say to them that it's safe to use. And we learnt this through COVID and from lots of other sort of immunisation programmes, that actually it takes many more conversations with patients to make sure that they feel that this is appropriate for them. And so I think that also feeds into some of the reasons why, as prescribers, we're a little bit more behind the curve. Thank you.
And just in terms of those that have been prescribed, so you've spoken about sort of difficulties in making sure that there is wraparound care. How is wraparound care working for those that have been prescribed? So that's usually falling down to interested clinicians and GPs, and in areas that are lucky enough to have a PCN dietitian. Well, I haven't even knew him, which is a real shame. Is that it's falling to us to provide those extra appointments, and when you have a finite capacity, it then means that potentially something else is having to be signposted or directed elsewhere, because we need to make sure that patients are safe and using the medication appropriately. So a lot of that is staying very much within general practice. Okay. Any, from your perspective, on the wraparound care in London?
Again, just sort of experience from my practice is that many of our patients that come to the specialist weight management service are accessing it privately. So we've had practically no patients who have been referred where the GP has already initiated prescribing. But we are adapting our programme because there are so many patients who are accessing it privately, we're starting to collect data to try and sort of produce the numbers on how many exactly of our patients that are referred into the service paying or self-funding on the GLP-1s, but also we are adapting the content of our intervention so that it sort of raises some of those concerns around lack of appetite. So it's almost sort of providing advice that's suitable for patients who are preparing for bariatric surgery and GLP-1s, which are sort of similar issues almost, as well as those patients who are not accessing it and are just receiving lifestyle intervention. So it's trying to kind of cover all within the same intervention.
Okay. And have you, just based on your sort of anecdotal evidence and sort of real life experience speaking to patients, have you had instances where someone has maybe started and felt it wasn't for them because of side effects and sort of gone for other options afterwards? You're nodding.
Definitely. I think we see that a lot in GLP-1s. I think that we probably underestimate the GI side effects especially. And I think we kind of know that now. So patients will start the medication and it may be that we escalate the dose and then they get worse side effects, and so we might have a conversation about whether we reduce it and then try again or whether we stop it completely. So that's ongoing. And then, you know, obviously we have to consider alternatives, but sometimes there aren't any alternatives. And so it's then having that conversation around, okay, we can't do this by, you know, sort of medication, but, you know, how about we refer you back into an education program, or how about we refer you to the dietitian? But there are, you know, sort of waiting times that go with that. So we do have patients that are, you know, who are frustrated because they, you know, aren't able to tolerate that medication. But we haven't got a specialist service that can really get to grips with, you know, why they have that relationship that they have with food. And actually, it's a conversation of, it might be the dietitian, but maybe actually it's talking therapies, and that takes time and knowing your patient really well to feel confident, I think, to address some of those sort of really difficult, you know, areas in their lives as well.
Thank you. I just want to come back to this pressure point, because the evidence we read suggests that over the next 3 years, there could be a generation of an additional 1 million GP appointments. That seems untenable. I mean, a question mark, I suppose.
It's one of those mic drop moments, isn't it?
Yeah.
It's, you know, how do you respond to that? So we know that the numbers of GPs are reducing and practices are reducing. We know that there are always campaigns. There's always a need for something else that comes up. And I think most practices are really juggling with how do we do good general practice? What does good general practice look like? And part of that is, you know, there might be a little bit of long-term condition management that we can tweak, and this probably falls into that category. But what we hadn't realised was the actual amount of work, the actual workload pressures that would go with, you know, sort of taking on a medication like this. It's not, we can see you in 3 months and you have a blood test. This is probably at 4 weeks, let's weigh you, let's talk about your side effects, let's talk about what needs to happen next. So it's much more, I think, than we ever thought. And then to put that with increasing prevalence of every other long-term condition, with new inhalers that come out and new guidance that comes out for asthma or COPD, we're constantly having to shift, and that means that our clinicians need to take time out to have a bit of headspace to make sure that we are, you know, upskilled. We can make sure that we're prescribing safely and appropriately, and that we understand, you know, sort of how all of these devices will impact our patients and who can use them, who can't. So that takes a lot. But then we have all the other things. So if we are trying to, you know, really shift into prevention, then actually we need to go and find those cohorts of patients who maybe haven't accessed us before. And so as much as we have those 1 million additional appointments, we also then have to think, well, if we're thinking about prevention, we have to invite more people in for reviews, and then we will increase our prevalence. If we're trying to detect cancers earlier, we have to bring people in and have those conversations. But if it's very difficult to get a GP appointment, or then how do we balance that? And I think what we can't do is ask our already overstretched teams, whether it be within general practice, primary care, or in our specialist weight management services, is to just absorb that without additional resourcing, whether that be from workforce, but certainly from additional funding. And we need to make sure that we are providing our staff with a living wage, and that they are happy to come to work, and that they get joy out of their day, or else we can't attract people to stay and work in London, and London's really expensive. So whilst we've been talking about all of the issues with patients, actually as a clinician and asking our workforce to come and work in London, we have to take into consideration that actually their wages need to cover the costs of living in London and commuting into London, as there are all those difficulties as well. So we have great staff, and what we want to do is to retain them. And in order to do that, we need to make sure that they're fulfilled in their jobs, and asking them to do more on already stretched budgets and time is just untenable, really.
Just thinking about workforce development and that figure that you've quoted, I would also like to make the point that allied healthcare professionals who are well placed to provide the wraparound care, so physiotherapists, dietitians, nurses, they can do non-medical prescribing. So thinking about, what is the pathway looking like? What is the most cost-effective way of delivering it in primary care whilst maintaining a sort of really high standard and highly specialised staff in positions to support these complex patients is really important, and sort of thinking about the AHP workforce development in that context.
But also for them to safely prescribe. Yeah. So as much as we say that somebody else could do it, we still need to make sure that they have, sort of appropriate clinical supervision, and that means taking those staff from somewhere else. So whether that be GP supervising our staff, we have to make sure that there is an addition to to the workforce, not sort of just shifting numbers around. That's important. Thank you.
Yeah, I mean, it seems there's two completely different worlds at play here. So so you've got the private selling or whatever, where it's estimated as 1.5 million in the UK. They're on that. I suppose that's probably at least in the 100,000s for London. And I've anecdotally heard people like putting pillows around their bodies, lying about their weight in order to get the medicine prescribed. And then you look at the NHS, where I think in May 25 it was around 15,000 prescriptions in London. So these are really, really different markets. Can the NHS even really be in that market? I mean, it seems as they're so diametrically opposed as to the ambitions, the outcomes, and you look at this 12-year rollout, and I just wonder, where do these marry up? Where does the NHS and the private market come together? It's so worlds apart at the moment, is it not?
Yes, it is. I think what we want to do is to make sure that we have a safe pathway. So if a patient informs us that they're on the medication, it's important that we add that to the medication list, so that we know. So if they come in and there is a side effect or there is a complication in the future, that we have a full, sort of account of their medical record. And I think that's the difference with what we are trying to do in the NHS and within, sort of general practice and, across the whole NHS, is that we need complete patient medical records, and that we are doing everything in our power to make sure that the medication is used appropriately and safely. In the private sector, it's unclear as to, sort of the information that they have. They may ask us, or the patient may disclose, but we know that our patients that we see on the NHS don't give us the full story. So I'm very concerned that they may not be giving their private providers the full story. And so we may inadvertently develop some more complications later on, because the medication hasn't been prescribed appropriately, because the private sector didn't have all the information to do so safely. Yeah.
Can I also come in on that? So I would also say that the private sector often works with the sort of patients who present with fewer complexities, which generally leaves the NHS with patients who are highly complex, lots of comorbidities, very resource intensive. So I don't know whether you're going to marry up the two, but I think it's really important for the NHS and Commissioning to understand that whatever outcomes the private sector providers are getting, perhaps they're not comparable to what we might get in the NHS and the level of resourcing that will be required in the NHS for the type of patients that we are seeing in these specialist settings.
Thanks. Assemblymember Boff.
It's an interesting point, but surely the more you don't have to do, the better. I mean, if we take, for example, the switch to vapes. Nobody should vape. Okay, public. Nobody should vape. But that's actually, the move has been good. The harm has been reduced as a result of that, as far as we know. The harm has been reduced. Can the same standards be applied to weight loss drugs and people getting it privately? Because the harm is being reduced and it's reducing the impact on yourself to deliver to those people who really do need some help. Do you see the logic of that argument?
So I don't think that we wouldn't, agree with that. I think for us, it's about the equity. It's around, as Dorothea said, around the complexity. It's really easy to cherry pick patients who just want to lose weight. That's it. They've got nothing else. We will get great outcomes, and that's fine. And I think we've always had within the health service patients who will go off and will make choices to go to pharmacy first, or to go to to use a private provider. I don't think that will change. I think what we're saying here is that we want a systematic approach to how we manage our obesity crisis in London, across England, across the UK. And so whilst I agree with what you're saying, it doesn't for the long term build sort of that trust if we are sort of saying, well, as long as you can pay for it, you can go off here and have a two-tier system. That doesn't work. And I think that patients do value being able to have a conversation first with a trusted, sort of clinician that they've known. Their GP is often that person. So whilst we may not be doing that in that ongoing prescribing, we're often the first point of call to ask, do you think it's a good idea? And if we want to make sure that we have equity of access to the patients that need it, I wouldn't want to take that away, because whether they're going directly to a private provider or not, oftentimes they will come and still ask our opinion on things.
I think I just want to make the point about the link between poverty and obesity, because there is a very clear link between those two. So we know that the weight-based stigma is the lived reality of our patients. They're less likely to get jobs. They're more likely to get bullied in a sort of school or work environment. They're more likely to suffer with poor mental health and discrimination because of their weight. And so we have that weight-based bias, and we have chronic sort of long-term conditions in this patient group as well. We have mental health complexity. We have social deprivation. Often we also have sort of different cultural diversity and belief systems around stigma, mental health, and all of those barriers. So I think it's really, really important to understand that the private option is just not accessible for the most vulnerable. So it's sort of making sure that...
I absolutely accept that, and I'm not trying to say, because what is it? £200, £300 a month for the private, it's a lot of money, and for that to be prescribed on the NHS would save those people a lot, and it would also mean on the NHS they get the wraparound services. So I'm not trying to say that this is the option for people in that, but it does take some of the impact off yourselves if those who can choose to go elsewhere for assistance. That's really what I'm saying.
But I don't think that that's changed. That could be for anything. Thank you.
Okay, thank you. I think that is brings us to the conclusion of this first panel. So can I give my thanks again to Dorothea Norton and Dr. Tamara Hibbett for what was a really, really good first discussion of our investigation on weight loss medication in London. We're going to adjourn for about 10 minutes and come back at 11:30. And thank you again to both of you for your input this morning, which has been really valuable. Thanks. Thank you. Welcome back to the Health Committee and welcome to our second panel of guests. Please can I welcome Suki Basra, Vice Chair of the National Pharmacy Association, Joanna Hollington, Principal Dietitian at Guy's and St Thomas NHS Foundation Trust, Nia Ramaya, Lead Clinical Advisor, General Pharmaceutical Council, and Socrates Papaflorotas, Founder of Newman. We're going to move on straight to the questions, if that's okay. Sorry. And if I come down the line, and I'll start with you, Suki, if that's okay, and ask, what are the benefits and risks of weight loss medication in your evaluation?
So I've been prescribing weight loss medication, the skinny jabs, for over a year now with my patients, and I work across the sector. So I'm a prescribing pharmacist working with the NHS. So those patients prescribed it through the NHS and privately. And a lot of the benefits that I've seen are not necessarily just physical benefits, it's the psychological benefits, changes in weight, changes in their health outcomes, whether they be cardiovascular outcomes, whether they be psychological, mental health, confidence. Those are the benefits. But the risks are the medication not being prescribed appropriately, and it being given to the wrong person, the patient that's not eligible, or patients that are vulnerable and seeking that medication from a non-registered site, someone that shouldn't be prescribing it, whether it be a salon, whether it be Facebook sites, Instagram. There are so many dangerous areas where patients that are most vulnerable could access. My biggest concern is trying to make sure that the general public genuinely know where they should be getting it, where they should be sourcing it, and having that confidence in their clinicians to do so. So you get incidents of pancreatitis and you get low HbA1c's where with the glucose levels drop, you get gallstone issues, and those technically tend to be where patients, A, weren't eligible to be prescribed that medication in the first place and somehow have got hold of it, so that's impacted their health negatively, or B, that the way that they've been prescribed is either too quick, so the incremental increases in doses have happened without consultation, they haven't had that wraparound care. All of these things are things that patients need to be aware of. And that's a responsibility I take really seriously as a clinician, to make sure my patients are really empowered before I even start the prescription for a medication. I will have an hour-long conversation with my patient before I ever prescribe. And then it's a continuous journey. So I've been with patients for over 18 months, every month having a conversation with them. And it can be anything from half an hour, 20-minute conversation, but making that joint decision with the patient of what they need moving forward. And every single patient's journey has been different.
Thanks. Could you clarify what's the pathway through which you prescribe, and what is the kind of rate or the fear or the risk of this poor prescription or those poor prescription services that you mentioned?
So I currently run a private service which is based in my community pharmacy, and all of my patients are known to me because they are patients that come to me every month through their other medication. So I know their history. I may see them every month. I may have been seeing them for the last 20 years. A lot of those patients I've had for a long time. So I've built a really good rapport with those patients. I know my locality. I know my demographic. I'm in Victoria in central London, so my patient cohorts are very diverse, both in socio-economic but also in their ethnicity. So I've got lots of multi-languages. I've got patients who don't speak English or have very little knowledge of English, but because I am their community pharmacist, I've built a rapport with those patients and I understand them. I understand their history and their health literacy, and I noted that in the last conversation. That was a really important point, and I think as a community pharmacist, that continuity of care has been there in that sector because we see our patients every month, day in and day out. And sometimes cross-generational. I've seen patients through the same family over 3 generations, and some of them 4. where I know the family, I know the history, the social history, sort of what their comorbidities are. So based on that, I can make a really informed decision of whether it's appropriate for them, including learning needs and language needs, and I cater each patient accordingly. And because I'm an independent prescriber, I choose to prescribe according to the clinical needs of the patient, and following my NICE guidelines and all of the other criteria that as a clinician I should be following. That's how I prescribe. But equally, I try to empower those that are asking questions, and they don't need an appointment to come in and ask. They literally just walk in. And there are studies that have shown that people that genuinely suffer from obesity, it can take them up to 16 years before they actually pluck up the courage to go and see a clinician about the issue. They may have been struggling with it for most of their lives, but the point at which you then finally decide that I've had enough, I need to go and speak to somebody, they have to think of somebody they trust. And I have seen through and I've been in my cohort, in my borough for nearly 30 years, they will come and ask me. They will come and ask my staff, because I'm seen as somebody, as a healthcare clinician that genuinely knows them and that they can trust me. They've seen me during lockdown. I was open during lockdown. They couldn't see their GP, but they could come and see me. I was my sector, the community pharmacy sector, was the only sector that was available for the general public to literally go and see. They could physically see their pharmacist, and we are trained healthcare professionals. So having that port of call in the community ad hoc for majority of very vulnerable people is really important. And that's why I think weight loss as a programme is so suited to the community pharmacy, because it is bespoke to each community. Every pharmacy has an inside knowledge of their community, and we should really tap into that knowledge base.
Just what do you think the prevalence is of these poor providers on the internet, and accessibility of poor providers?
That's really difficult to say. It depends on, I get a lot of feedback from my own patients that will tell me about a facial therapist or a hairdresser or a personal trainer that's actually approached them and said that they would they like to have a skinny jab. Only yesterday I had an email from a patient that is in my cohort that I've been prescribing for nearly 15 months now, who forwarded me a photograph of a personal trainer showing her a box of fake skinny jabs, and he was offering it to her openly. And she was a very good patient who then said, "This is what's happening, Suki. Is there something you can do about it?" Obviously, I'm bringing it to your attention because I think as a healthcare professional, I'm really worried about that, because I know those patients that I deal with on a day-to-day basis will actually come and speak to me. And in every area, I'm hoping that the public will go to their pharmacy and ask their genuine healthcare providers what is the safest way to get their medicines. If they think that it's okay to buy it from a personal trainer or a hair salon or a hairdresser, that means it's our responsibility to educate the public to not do that. And I take that as a vice chair of the National Pharmacy Association really seriously. I'm trying really hard to advocate for safe prescribing.
Thank you. And Joanna, coming to you, what is your evaluation of both the successes and the risks of weight loss medication?
So I think if I just start with the pros, so a lot of the things that we're seeing in clinic, obviously, is weight loss for people who are eligible and it's working for. You have the kind of metabolic benefits, so things like the kind of cardiovascular, diabetes, blood sugars, reduction in sleep apnea. There are changes in mental health, and there are changes in eating presentation. There's some really interesting research going on at the minute around binge eating disorder, and actually these medications making it sort of alleviating a little bit. There's changes in food noise, and for some of these individuals it's really exciting for them to suddenly not be so burdened by wanting to eat certain foods or eating at certain times. So it's definitely beneficial to patients who they're eligible for it and it's working. But the downsides need to be really managed, and the risks, and we're seeing, particularly obviously from an NHS background, we are seeing micronutrient deficiencies, and ones that are quite rare and only seen in bariatric surgery, so zinc and copper. we're seeing people who are losing weight too quickly. Perhaps they're under our services in the NHS, but they're getting it privately, and then they're not actually being monitored by us for taking this medication. If they lose weight too quickly, that might affect their muscle mass. There's something really exciting about losing weight, and what we're seeing is some individuals are then sort of going a bit too far, actually, and then they're excited by the lack of appetite and therefore losing weight too quickly, losing muscle mass, sometimes losing hair, which can happen with fast weight loss, and then putting themselves at clinical risk. So it is a really great medication for the right people, but it definitely shouldn't be something that isn't provided, you know, as you're just mentioning, on its own. It really needs to have wraparound care. So it needs dietitians, it needs psychology, it needs registered healthcare professionals who are able to support those individuals with starting it and then the journey with it. And that's a huge piece. It's the kind of working with the medication, not just starting it from, you mentioned somewhere online, or just starting it and then not having follow-up care and not being mindful of the foods that you're eating and your nutritional kind of complexity of what you're having, basically. So making sure you're actually eating the right types of food, because there is a risk of under-eating with these medications, and there is a risk that somebody can eat ultra-processed foods, just less of them, and sort of, running the risk of deficiencies and issues with their health from it.
Amazing, thank you. And Neha, from your perspective as well.
So from my perspective, from a regulatory background and representing the General Pharmaceutical Council, what we're seeing is the benefits of course, like the private services providing these online private services that are largely online, providing these weight loss services. There is a benefit around accessibility and people being able to access these medicines in an efficient way. And we're also hearing from our focus groups and our engagement groups that generally, not just with weight loss, people are liking being able to access medicines online and being able to access their treatments. There's obviously the benefits of weight management and the other comorbidities associated with high weight, such as like the blood pressure being managed and cardiovascular risks being lowered. And whilst the GPHC is promoting and supportive of private care and innovations and online digital services, we also acknowledge that there are lots of risks that come with this. And we've seen cases where the wrong people are getting the medication, so people that are underweight, or in some cases we've seen young children, when I say young children, I mean 16 and 17-year-olds, managing to get hold of the medicines as well. We've also seen cases where people of low weight are obtaining them. And I think we need to acknowledge the risks are, like especially with the online service, is that the face-to-face element is being reduced as well. So you can't physically see your patient. And so our guidance and our standards would expect that pharmacies that are providing these services are assuring themselves that the medicines are safe before they prescribe them. The other thing that is a risk that we're seeing and we're hearing about is the lack of access to national care record by private services. We know that some services are being able to access national care records, which means that they do have a little bit more information about the patient. But overall, not all services do have this access. So that limits their ability to make informed decisions. And it also means that people need to, or pharmacies and providers need to find other ways to assure themselves of the reliability of the information that they're receiving. The other risks are, which we've addressed in our guidance, and I know that's another point later on, is around people using questionnaire-based models only to provide these medicines. And so there's a lack of assurance when you're prescribing there. So, yeah, like I said, whilst we're very supportive of private services and particularly online services as well, because that's the part that we're seeing more of, we do think that the risks need to be managed very carefully in this situation.
Thank you. And Socrates, to you, the same question as well. Sorry, just the button.
Yes, the button, of course. Thank you, Chair, and members of the panel. To echo some of the comments earlier, I believe we're still in the early phases of understanding the full benefits of an integrated approach to obesity care through a combination of pharmacotherapy and behavioral change, of course, GLP-1 medications. At the moment, we're seeing some of the, if you like, first-order effects. People are losing weight. People that have struggled to lose weight, some of them, pretty much for the whole of their lives, they have a reliable way to lose weight. We're seeing improvements in key biomarkers around their HbA1c, hormonal health, and of course, we know that some of those medications are being proven to have also cardioprotective benefits. What we're excited about and what we're working on is also doing the research and collecting the evidence to be able to understand some of the second-order benefits that this approach is having. And I'm thinking here about productivity. I'm thinking here about quality of life. I'm thinking here about prevention of conditions that we know are related to obesity, such as diabetes, cancer, hypertension, and a whole bunch of other comorbidities. So we're seeing right now the things that we can measure immediately, but I believe we're collecting evidence to be able to prove the overall benefits that we can get from these medications. And I think it's important, I was listening to the panel earlier, to be able to share learnings, share data, and be able to understand exactly what the effect is. When it comes to risks, we also are concerned about inappropriate prescribing and inappropriate access to medication. We also have heard the stories of people buying this medication in the pub from all places, and I really don't understand why that could be the case. You've seen some of the recent news around price increases of one of the medications in the market. We are seeing a rapid increase in searches online about alternatives. We know that we do have a problem with fake medication and with black market access to medications that are not even out of clinical trials right now, but people are buying the active ingredients of some of those medications. So that is a risk, and it's also a risk because the downstream effect of that will also affect, I think, all of us and the general public. We do welcome the steps towards stricter regulation and enforcement of actually providers on how they onboard patients, how we can assess capacity, how you can verify somebody's weight so that we can prescribe safely, and then crucially monitor patients as well as they go through that journey. With Newman, we do provide, from the start, we never provided access to the medication alone. We always provide it as part of an integrated program that includes access to a clinical team, access to a coach, and access to a platform that can help you understand side effects, personalize your journey through treatment, and then support you with all the things that you need to be doing while on medication to become healthier. Things like exercise, nutrition, mindset, and sleep, so that you're not just losing weight, you are improving your body composition, you're setting yourself to be healthier today and healthier for the future as well.
Thank you. I think this is something that in some ways some of you, a lot of you have touched on already, but what safeguards do private sellers have in place for customers at the moment, and what should be the kind of standardised norm for those safeguards? Does anyone want to come in on that? Yeah, it's okay.
I was going to say a lot of learning can be taken from the community pharmacy sector, because if we are thinking about integrating this into the NHS, we need to be looking at a sector that is part of primary care, and that is your community pharmacy, which is a bridge between NHS services but also private services. And if we want to try and connect all of that and provide that safety network, then within the community pharmacy, you have a profession that has access to NHS, but the summary care records, which allow us to check what medication a patient's already on. So if they're on repeat medicines, we have access to have a look at that. As a sector, I'd really like to see us to have access to patient notes, because we are also trained clinicians, and I feel that then it allows us to make much more clearer clinical decisions. Now, being a community pharmacist, you already have your own records of what medication you've given to that patient, and if they come to see you, you can then prescribe accordingly. But I think as a safety net, it's It doesn't matter whether it's online or whether it's face-to-face. As long as that patient has been spoken to visually, has been seen, where it be a virtual consultation through a video, or whether they physically come into your pharmacy. I think that element of a proper consultation is really important. And you've got a sector that spent a year learning that. And that's where we've picked up on the loopholes that are present, where a questionnaire is not sufficient. It is not enough to just do a questionnaire. You wouldn't do that for blood pressure medicines. You wouldn't do it for any other medication. And this should also be seen in the same light. And I commend the fact that the GPHC has picked up on those things and it's monitoring them more so those online suppliers that perhaps, you know, there are some big organisations that initially perhaps prescribed according to that. But we're learning, and that learning needs to be taken and extracted. Newman has also made that really clear that there is a lot of clinical data out there through pharmacies that are registered professionals that can tell you what works and what doesn't work and how it works, and implement that into an NHS pathway. Equally, you've got a sector that's already the bridge between the two markets, the private and the NHS. So they're in a perfect position to roll out straight away. You've already got skilled professionals who know the medication. I have GPs that will ask me, how do you use this medication? How do I prescribe it? Because they're not experienced. And I don't blame them, they don't have the capacity. I have diabetic nurses that will come and ask me to train their patients when they've prescribed it through the NHS. So a community pharmacist is dealing with both the diabetic patients and the weight loss medicine patients. It's the same drug. It's not a new, in its capacity, it's not a new drug, but the knowledge base that you've got is already there, and we need to tap into that to make sure that we don't make any mistakes moving forward.
Thanks, Suki. Is there anybody else on the panel that's come in on that?
I can comment from our perspective and also some of the largest digital health providers. We are absolutely, for the last, we've started, these medications have become licensed and available only over the last couple of years. So we were absolutely, especially in the early phases, learning. I think even the pharma companies that produce these medications were learning themselves patient behavior at scale, adherence, side effects. It's really important to understand that you need a combined multifactorial way of understanding and connecting with patients that can include a phone call, a video call, a visit to their pharmacy, access to the summary care record, information that you can provide from them, technologies that are emerging that are getting validated so that you can be able to extract better, deeper information about a patient. We believe that we are all, we're trying to solve the same problem. We have a very similar mission, which is to make Londoners and people, all over the country healthier, more active, happier, give them the ability to live longer and to live longer in good health. So we need to find ways that we can increase also interoperability, increase the ability, for patients that come to us. We also require them to consent that we can inform their GP when they become a member of Newman, and I know a lot of other providers do this. It's very important that we set the standard that ensures, one of the biggest, we talked earlier about one of the risks, and one of the risks that we also need to figure out is equitable access at scale. We need to find ways that we can continue the care journey between different parts of the ecosystem. We would love to be able to, some of the things that we do that are, let's say, able to, we can make them available to more people at a marginal cost that could be quite low. We find ways to do that. People that perhaps, I heard one of the questions earlier, cannot get access to the medication. Can we support them in ways that are perhaps purely digital, but also put them in the hands of people that can use them to be more effective as clinicians that practice every single day. I think I do expect us to be able to start getting closer as different entities and governing bodies and providers in the space to not just share lessons, but also share access and information about our patients as well. But yeah, ensuring patient safety and making absolutely sure that the right people get access to the medication, they use the medication the right way, and they're there to, they get the support that they need throughout that journey while on treatment and after is going to be crucial, because I believe obesity at the moment is at about 30% of the population, and it used to be about half of that 25 years ago.
Yeah.
I just wanted to add a comment from my experience in the NHS. So it feels like there's two separate pieces. There's what I guess you've just mentioned as black market, which we are seeing in our patients. We're seeing in this cohort, they're coming in, they're talking about, drawing medication up from something, which is not how you take this medication. So, and they're getting it from, as you said, from maybe beauticians, from many places that obviously are not official. So we're then picking up and mopping up that kind of care in the NHS for people who are taking these, may not even be a GLP-1, for all we know, it's not actually that medication, right? And then you have the above board and the legal prescribing, which is all your online pharmacies, which they do have, they ask for photographs, they ask you to fill in a questionnaire, but we know there's lying going on. There's people stealing photographs of their friends. Who knows whether people are using AI these days? And, when it says, are you at risk of, any history of pancreatitis? People might not know if they are, or they might just say no, and then you're getting these rise in patients with acute pancreatitis then being admitted, needing kind of urgent health care. So the NHS, running kind of weight management services, we are seeing these patients in our services, and then we're also then having to support these individuals. So private care is actually also putting a pressure on the NHS. So it's not just vice versa, it really is that is then the NHS is kind of that infrastructure that are managing some of these complex cases.
Thank you. And just to echo Joanna's point as well, we are seeing similar where patients are inappropriately accessing medicines as well. But just for a point of clarity as well, the online provision of medicines can come from multiple parts. So there are online pharmacies which are registered by the General Pharmaceutical Council, but also online providers which aren't necessarily pharmacies, so won't be registered with the General Pharmaceutical Council, but are registered with CQC in England or other if it's Scotland and Wales. But in terms of the safeguards that we put in place for pharmacies and for private pharmacies as well, we do have our standards and guidance, which we expect all pharmacies to follow. So we have our standards for registered pharmacies, and we've more recently got our updated guidance for pharmacies providing services at a distance. And within that, we do expect pharmacies to identify the risks of the services that they're providing, including the medicines and the treatments that they're providing. We would expect that they've identified any kind of safeguarding concerns within that as well. And also around that they're keeping appropriate records, that they're also accessing patients' records to justify their prescribing. And like you said, Joanna, around the using AI, that's at the forefront of our mind as well for the photographs. And which is why we then say that we would expect that assurance to be in place, that they're either communicating with the patient's GP or they're using two-way communication to assure themselves of that supply. So they're the kind of safeguards that we're really expecting pharmacies to put in place.
Thank you. Suki, you wanted to come back in?
Yeah, I just wanted to add that there are lots of us clinicians that are doing a good job that are turning patients away. So I've got experience where I've had a new mum who is breastfeeding her baby and is pressurised amongst her WhatsApp groups that wants to lose weight and has come in to see me and say, I'd like to lose this weight. She's got a BMI within the criteria. But I had to have a long conversation with her and actually tell her that wasn't what she needed right now, and that she needed to nurture her baby, she needed to carry on breastfeeding, not to fall into those pressures. And this was a really young mum, and I think that it's really important that we as clinicians can have those conversations with those who are vulnerable to the social pressures that are happening there. And I think what you won't hear about is the number of times that we actually turn people away. But equally, I'm mindful that I, as a clinician, have turned that patient away. Is there somewhere else that person will then access it? And I'd really like to have some help to try and stop the sort of underground access that patients are getting, whether it be through educating patients to make sure that that isn't the right way to go, or whether it means that as a London borough, we can try to police that a lot better, because we know that salons and we know that Instagram sites and Facebook sites and all of these things are happening within our locality, and the majority of the local people know who's selling it. And obviously, they won't tell me because they may feel that I might forward that information on, and there's a bit of loyalty going on. But we know it's happening in London, and it sometimes impacts those that are most vulnerable. So some of my patients, like I said before, their language difficulties are there. I have to provide them with bespoke food plans based on their language or based on their social economic circumstances. I have a patient that's a refugee that really wants to go on this medicine, and I'll give it to her at cost price because I'm concerned that she is going to go and buy it from a friend of a friend that then will put her at risk. And she'll spend money that she doesn't have. She's not eligible on the NHS. And I worry as a pharmacist that sees her month in and month out, that how am I going to protect her? Now, if I were able to have access to the NHS pathway where I could then identify those vulnerable patients that are the ones that are going to be fall prey to a Facebook site or a salon, I want to be able to use my due diligence to be able to prescribe for that patient using my NHS hat. I deal with medication every day. I am prescribing for the last 28 years NHS prescriptions. I know my patients, and I'm not saying I'm unique. I'm saying that every pharmacist, if they are in their community, they have this unique knowledge within that community of who is the most vulnerable in that community, what cohorts are the ones that are going to fall prey to this kind of thing, and then ultimately put a burden on the NHS, because that's the patient that's then going to run to A&E because they've had a side effect from a dodgy medicine. But they won't get it from me because I can only provide it through a private mean, and it costs me money to get it in, including the price spikes that we've had. I have to forward that on to the patient. I need to survive. I need to pay my bills as a community pharmacist. But then that puts us in such an awful position that how do we juggle protecting our patients but also trying to guide them in the right direction? I feel like as a sector, we are really well placed to try and bridge that gap, and we're able and we're willing. We would just need that support to be able to do it.
Thank you. Sounds a bit of a catch-22 that to do the right thing and turn them away, you might put them into more trouble. Neha, you wanted to come?
Thank you. And just to add to Suki's point as well around the pressures on people through social media. So that's something else that the General Pharmaceutical Council is hearing a lot of, that we're seeing inappropriate advertising, whether it's via social media, Facebook, Instagram, TikTok, and also through like mass emails as well being sent to people to, particularly with the price hikes, to bulk order as well. So again, I would welcome the support of the committee to help address some of these problems as well.
Thank you. Assembly Member Boff.
I think we've heard quite a lot of evidence about how people are accessing these drugs inappropriately and not in a good way for them. But are there private sellers of the weight loss medicines that are providing wraparound services? Perhaps Mr. Papaflonatis.
Yes, absolutely. So Newman is, first of all, we are a multidisciplinary team when it comes to treating patients, but also we are one of the providers that is registered both with the Care Quality Commission and the GPHC, and actually the MHRA, because of the way that we procure some of the medication. From day one, the Newman Obesity Care Program included access to pharmacotherapy, primarily tirzepatide or semaglutide, Mounjaro or Wegovy, access to a clinical team that includes a prescribing pharmacist, if necessary, a GP, but also access to the Newman mobile app that has a number of tools that can help people understand and report side effects, track their progress when it comes to their weight, but also access a coach that can be a dietitian, can be somebody that has trained as a health coach. We have a very experienced dietitian as our VP of Behavioral Medicine, and Zoe designs our behavioral support program, again, around the core pillars of health, sleep, exercise, nutrition, and mindset. Every Newman patient gets access to that information. This is all provided under one treatment plan. We don't ever provide the medication on its own. We're working to be able at some point to have a program that doesn't include medication at all. So it is purely based on behavioral support and healthy behaviors, and then helping people understand it's still, one of the biggest challenges that we have, especially when you think about London and the diversity of the communities within London, is different cultural backgrounds, different risks according to ethnicity as well when it comes to obesity, but also very diverse habits and education when it comes to nutrition and exercise. And we need to be able to reach those patients where they are. We need to be able to have a program that caters, again, for the people that might be on a very different part of that journey and they require specific support on how to exercise to increase muscle mass, all the way to the people that need to understand what healthy eating is and how you can help them in practical, affordable ways to get there. So this is the program that we always offer to a patient. We're now investing, we've been investing for the last 18 months in using some of those new technologies that rise from artificial intelligence to be able to provide an always-on coach that can help you, not with things that are clinical or medical, because that's falls into a very different domain of regulation and safety, but with things that are behavioral or informational, that can include the personalized nutritional plans that were mentioned earlier, that can be customized to different languages, that can be customized to the needs and the habits of the individual person. That's where we see a lot of ability of technology to augment and assist the amazing job that our clinical team is doing. And the clinical team that we have, about 35% of our team has a clinical background. So we believe technology and data is there to augment humans in a safe and appropriate way, but then be on the side of the patient every single day, be fully personalized with them, and then be able to guide them through that whole journey. I think one of the, when it comes again to benefit and risk, we have at the moment, I believe, about 2 million patients that are on an active GLP-1 prescription nationally. And on one hand, that's amazing news because, we're starting to bend the curve when it comes to obesity and tackling a crisis that would put us on about 50% of the population being obese by about 2050. So that is amazing. But then what we're also thinking is what happens with long-term access of those patients? What happens to cost, which is the biggest factor for people stopping treatment right now or pausing their treatment? What happens also to the people that don't want to continue medication for whatever reason? Those are the people that we need to be able to support. And for me, what's exciting is that those people, those 2 million people, they are going through a massive transformation in their lives. It's, for a lot of them, the first time that they have been able to fight this problem. And we have a golden opportunity right now to do a really big job when it comes to prevention and use GLP-1s and anti-obesity medication as a catalyst to put people on better health. But that requires a lot of effort. It requires resources. And again, I believe it requires partnership and coordination between all of those different parts of the care journey, public or private. I don't see any other way. If the ambition is to give access to everybody and to be able to, whatever the right access for them is, and to do it in a way that we can afford, I think that's the best way to achieve it.
So it seems to me like the first priority is for them to lose weight and the second priority is to get them off the drugs.
Long term, clinically, some of those patients will need to be on this medication for a very long time. And when we said earlier about learning, we are learning really what is the long-term behaviors, outcomes, and support that people will need. But yes, I believe our goal, our mission is to help you be lead a healthier, happier, longer life. And the best way to do that is to use medication strategically and then put you in a position where you don't need it. And then keep you safe and keep you supported throughout that journey and be there when and if you might need it again.
Thank you. Ms. Basra, I mean, are there private sellers who are providing these wraparound services?
I think we're here today to really think about the Londoners. And when you think about Londoners, you've got to think about all of the demographics. Where are they accessing? What's accessible to them? 1.8 million people will walk into the doors of a pharmacy every day. That's nationally. And there are, per pharmacy, average 5,000 to 6,000 patients that they have in their sort of cohort, but that's their regular patients. You will have ad hoc patients walking in, don't need an appointment. So within London, every patient is in within 20 minutes walk of a pharmacy. So they're registered healthcare professionals who are experts of medicines. So for our Londoners, we've already got a neighbourhood of qualified clinicians. And if we're looking at the NHS 10-year plan and we want to implement something for our neighbourhoods, the clue is in our profession's name. We are community pharmacists. We know our communities. We know our neighbourhoods. So I really think there is a space for online because there are patients that can't access it. But we're talking about Londoners. Londoners actually could really benefit, especially the most vulnerable. They may not be able to access online information. Language. Every pharmacy has a diverse team. I have Eritrean speaking, Arabic speaking, Polish speaking, Gujarati speaking in my community pharmacy. So I can cater for the needs of my patients. They need to have access to the right information, safe information and regulated information.
I get that. I get that. And you'll find nobody with greater respect for pharmacies than me. But are there other people, are there other providers who are doing this responsibly? This is what I'm trying to get at. And we know Mr. Papafroatis Numan is doing that.
Yeah, I do that myself. I can only speak for myself and my colleagues that I talk with. There are other online providers that provide proper face-to-face consultations, making menus for them. It's there, but they need that support as well, I suppose.
And if we go on to Ms. Ramaya, you pointed out the recent review of the pharmaceutical guidance. Perhaps, Ms. Basri, do you find that adequate? Does it cover all the bases for you about that guidance?
So, as a National Pharmacy Association, we've really pushed for the regulations to be improved, and we're really happy that the GPHC has taken on board a lot of our recommendations. And that's because our pharmacists and community pharmacies have identified where there are loopholes and there's gaps. And so they are working with us, and we represent almost 6,000 pharmacies in the country. And that information, that knowledge base is being forwarded to the GPHC, and they're working with us. I'd love to see better monitoring of those that are not following the rules, but that's all to do with capacity. And some of it may not necessarily be to do with registered pharmacies on online sites. It could. I think our biggest concerns is the grey market, where I can't police a gym, I can't police the hairdressers, and I can't police the online sites. I can only rely on my patients giving me that information. Yeah. And that's where I think we need the help from our local authorities.
I mean, I anecdotally, I've heard of people who've been offered the weight loss drugs, at a gym, for example. So we know it exists. I think it's important for us to point, for those considering using this programme, that there are routes where that can be done responsibly with their interests at the heart of the matter. Ms. Hollington.
I was just going to add that wraparound care in private sector is actually optional, so it's not mandatory. So somebody can go onto an online pharmacy and get it, and then go off and just be taking it. And I think the issue is that it's if having wraparound care is optional. When it's private, it will come at a cost to the patient. Ergo, you actually will run the risk of patients not having wraparound care. And what that means is making sure they've got dietetic support, psychological support, they're actually losing weight at the right rate. So I think the problem is that wraparound care, when it's privately prescribed and not above board, sometimes it is. I think that's the main problem, is it's optional.
Yeah.
I was going to say the GPHC have set those standards, so as a prescriber, it does include wraparound care. We should be following the NICE guidelines. So I don't think it's about those that are already, if they are not providing that wraparound care, then they're not doing it properly. And that's how do we police those people that are not providing it properly?
Well, I think the guidance is about providing two-way communications, isn't it, between the patient and the prescriber. This reminds me.
Yeah, so you're right. So the guidance that you're referring to is for online providers. And yes, we do within that have strengthened points around, well, first things, we've included weight loss medication as a medicine that requires extra safeguards. And that's because since the previous publication of the guideline in 2022, we've seen increased concerns about weight loss medicines. And we also acknowledge that weight loss medications can be misused by, due to social media pressures, people underweight getting them, those with eating disorders being able to obtain them. So we have added that medicine as one that requires extra safeguards. And around that, what we've said is that we do expect the two-way communication. And the two-way communication is described as being for the patient to be able to communicate with the prescriber or the online provider, and the provider can also then speak to them and their GP. So that's one of the points. We've also, within that, said that we'd expect independent verification of someone's weight and height. So Joanna highlighted earlier around pictures being used, and of course, pictures alone are not an appropriate way to recognise someone's weight and height. And we also acknowledge that some people can use AI or pillows, I heard you say in the earlier panel, to make themselves, look bigger. So we'd expect that independent verification of their weight and height. But overall, for people with long-term conditions as well, it's about independent verification of the information that's being provided. Now, whether that's through two-way communication or speaking to someone's GP or being able to access someone's record, that's all part of our additional safeguards that we would expect. But that's, specific to online provision. And just to echo again on Suki's point earlier about the people that we don't regulate, so yes, it is, the black market and the grey area, but there's also providers based outside of the UK and, based in EEA and EU countries that can, legitimately send prescriptions over into this country. And that's an area that's not being regulated. So it's a circumvention of UK regulation.
Of course, all this two-way communication, especially when it applies to the NHS, has cost to it as well, doesn't it? I feel really guilty when I'm on statins, like most people of my age, and every other prescription I get, I have to be interviewed by a GP to make sure that I'm all right, and it makes me feel guilty. I think you should be going talking to some sick people, right?
But I think you sort of raise a really relevant point that. And I know I am here to represent pharmacy. I'm trying to educate you on the untapped capacity of an NHS-based sector.
But do you have that capacity?
So I am talking to patients every single day, and I have to give them my time, and they don't book an appointment to come and see me. So I could literally be serving a patient, and suddenly they'll say, Suki, I want to talk to you about my statins. I'm not sure if I should be taking them.
I get that.
Kind of conversation.
I get that. I don't want to talk about statins, but it was just...
You raised the question.
Yes, I did. Yeah. I did.
You started it.
I just get very annoyed with it, that's all. But do you have the capacity? Do pharmacies have the capacity to meet the demand for weight loss medicine?
Do you know what? A lot of the capacity for weight loss demand has been taken.
You're good at it. I'm not taking away from the fact that you're good at it.
Thank you very much. I'll take that.
But do they have the capacity to do
those that have got the capacity are taking on that capacity despite the pressures because of the demand. I don't know how much you know about community pharmacy, but we are so agile. We literally I have to be reminded when to go to the loo. You know, I am literally talking in the morning, I need to go to the loo, my dispenser will tell me 3 hours later. We just squeeze in as much as we possibly can through loyalty, and we're not being paid for everything. So there's a capacity, but there isn't a support. And there's a capacity that's been squeezed. And I think what we're asking for is we've got the capability, we've got the competency, and we've got the skill set. We've also got the knowledge. So we've got a year's worth of private sector work that we've done for ourselves, and we've built up a knowledge base like the online sites. So we've got data, we understand weight loss, and it would be nice to be able to work with our dietitian colleagues through the NHS to be able to refer. I think as a government, as an NHS, we need to now try and provide an already trained up workforce. It's not even about giving GPs training. You've got a sector that's already learnt what to do, and they could work with the dietitians, social prescribers. I feel like I'm sometimes a social prescriber, a dietitian, a mental health counsellor, all in one, and I'm trying to do it all, and I'd just like some help.
Yeah, so you're arguing for a wider role for pharmacies, for more...
To be able to
not powers,
roll it out through NHS.
More opportunities to be able to call in other support for your...
and just being able to bridge the gap between the NHS and... So my patients are coming in through the door asking, Suki, am I eligible? No. Suki, am I eligible? No. Suki, am I eligible? No. But can I get it on the... can I get it privately? Yes. Oh, it's really expensive, I can't afford that. They've gone. Or, yes, I'm prepared to pay for that because I can pay for it. My concern's the people in the middle, that I would like to give it to them on the NHS because I know they're on universal credit. I know they've got long-term metabolic syndromes that actually could benefit from it, polycystic ovaries, they've got thyroid issues which make it harder for them to lose weight. As a clinician, I recognise that, and I want to be able to help that group of patients.
Is it fair to say, perhaps Ms Hollington can come in, that actually those people accessing these treatments privately are actually taking some of the weight off the NHS? So that wasn't a pun, instead. I just realised it might be.
Yes and no. So they are obviously seeing some patients with the medication, which means that we're obviously not having to prescribe. But with the cost increase, I think some of those patients are now going to start trying to come into the NHS, and they're eligible for the medication privately, but they're not for the NHS. So actually, I don't think they are taking the pressure off. For some patients are taking the medication and still using our weight management services. So I don't think so. I think it's actually probably kind of evens out.
Because it does strike me that if people are accessing it privately, for one thing, the NHS is not paying for the drug. I take the point about the wraparound services may still apply to the NHS, but they're not adding to the drug costs of the NHS in that respect.
Not yet. But I was just going to say on your piece there around, I think that community pharmacy, they have infrastructure, but what you mentioned there, like you're relying on goodwill and you doing loads of jobs and not going to the toilet, like that shouldn't be what this is based on at all. It should be actually you've got the right resource in the right place, which community pharmacy is like a spoke and hub model. You've got pockets everywhere that you can use as the infrastructure, but not the sole way of getting it. I think you need more time and you need MDT support. You need dietitians. You need that, you need like a clinic room in a pharmacy for this wraparound care. So I think it shouldn't ever be based on you going above and beyond and doing every single person's job, because that's how burnout happens. And we've got a lot of that in the NHS.
I think the point of that question really is that we know pharmacies can do it, but if they haven't got the capacity, we don't want to break them by asking them to do more.
It'll take more than that to break me, though.
Mr. Papaforatis.
If I can also just add to that and maybe go back to the previous point, I think we've got more than 10 million obese adults in the UK right now. I think they're closer to 15 million. We have the gap between where the prescribing guidelines are now and the people that do qualify for access to GLP-1s is still pretty large. I believe the vast majority of prescriptions for GLP-1s up until this point have been private prescriptions. Of those 2 million, I don't have the number off the top of my head of what are NHS prescriptions, but they're still in the, I believe, low single digits. And we do want access to increase through the NHS. We do want people to have access through their community pharmacy, through their GP. But I do also believe that for the foreseeable future, we're going to have to find a way to get those patients through that journey, through the right touch points, and being able to coordinate better so that we can support the different parts of the ecosystem. We can give people safe access through the regulation that is now clear that should make the wide, safe access to the people that need this medication done in the proper kind of way. We are big advocates in partnership and interoperability, so being able to, again, that opens up a whole other conversation. How do you ensure things like cybersecurity, make sure that the people that get access to that information are doing it the right way? I believe there are steps that we can take there to make that better. We are seeing the MHRA open up an AI sandbox recently to be able to invite, again, select providers. This is a safe environment so that digital healthcare providers, medtech companies can develop solutions that use data and artificial intelligence to be able to provide validated solutions that are safe, that can support patients. And I believe that is really important. I do believe there's work that is happening across the NHS, different ICBSs, and I think London has a key role to play, given the universities, the technology companies, but also leaders on this table that are engaged in the problem, to be able to find a way, how can we get from those 2 million people that are getting treatment right now, get to 15 million people that could get treatment, but not in a way that means that everybody stays on GLP-1 forever, not in a way that means that you are dropping, I don't know, not exactly hot potatoes, but you're sending information to somebody that is already at capacity. And I'm not talking about Suki here, of course. I'm talking about maybe a local GP, for example, that might receive this information, but they don't really have, they can, if I can say one story from one of our GPs that practices at Newham, and he was sharing the story of a patient that came to him with knee pain. She had a couple of conditions with both her knees, and she needed orthopedic surgery. By the time she got the referral to the orthopedic surgery and she was seen, she was actually assessed as needed to lose weight before she could have the surgery. Right. By the time she was referred to have the consultation, because she qualified for GLP-1s, about 18 months had passed by. And when she turned up for that consultation, which was a digital consultation, and this was a person that access to digital technology wasn't as easy as perhaps, some of us here. She stayed on that call for about 45 minutes. The call didn't happen for whatever reason, and then she got a letter that she was discharged from the service. And then she was back in tears with her GP because she just didn't know what to do at that point. Now, these are stories, I know they're not the norm, and I know there are very good reasons that things like that do happen and there's no easy solutions. But these are some of the realities that patients face in their day-to-day lives. And I'm not suggesting, by the way, that digital health providers are the silver bullet in solving these problems. For me, what I'm passionate about is figuring out a way for us to be able to really give the service and the support that each patient needs, and then do it safely, but do it at a scale that can make a massive difference to national health as a priority. But I'm hopeful that perhaps, some of these conversations and with the London Assembly, there are ways that we can start sharing data, we can start sharing learnings. Maybe there's a pilot that we can do somewhere locally in more closer collaboration, and see if there's a new model out there that we can start working towards over the next few years.
Yeah, well, the silver bullet for most of London government is to get us not working in silos. So, and try and get that data sharing, which all sorts of reasons we can't do, and it doesn't apply to just this subject. I can tell you, it's just about everything. I mean, we were talking about the costs. What do you think, Mr. Papafloratos, about the impact of the price of Mounjaro being increased has had on the effect of the supply and access to treatment?
It's a little bit early to tell right now because the prices really took effect a couple of weeks ago. What we saw was increased anxiety from patients. We actually had to stop onboarding new patients on Mounjaro because we believed that people were stockpiling medication, and we wanted to stop that. So we stopped actually prescribing to new patients, accepting new patients for a few weeks after the announcement was made. I don't believe the increase of 170% will actually be the increase of the medication when it propagates.
Yeah, almost nothing Donald Trump says he's going to do actually ends up happening, so perhaps we have some hope.
But we saw that people they want support. They are concerned about what would happen to them. I am worried that people will stop treatment, and they will. I am worried that people will go and find alternatives that are inappropriate. I believe the search term alternatives to Mounjaro increased by 5,000% during that period of time. We know there are alternative medications, but they need to be prescribed safely, and it is not as simple as.
So there are competitors. There are competitors to Mounjaro for people with similar.
There are other. There is an alternative similar product to tirzepatide, which is semaglutide, which is Wegovy. There are over-the-counter products. There are some older generation medications that are still effective, like liraglutide, like orlistat. There's a number of options available. It's difficult to really explain and understand even why Mounjaro became as popular as it became in the UK market, but there are a number of solutions available. Again, we would like to think that there are alternatives to medication as well. But right now, given where people are, where their focus is, we just need to make sure that during this period of transition, until we know exactly what the new kind of conditions are, we support people during that process, and we do it the right way.
Thank you. Ms. Better.
There isn't an actual like-for-like alternative. So the other alternatives are the first generation of GLP-1s. And so they will work psychologically, they work on the brain. So the pathway, the alternative works on one pathway, so it suppresses appetite. And then the upgrade with the next generation of what Mounjaro is it worked on two pathways. So it's about the noise and the appetite and stabilizing the sugar levels in the body. Now, I haven't had a single patient that I've actually changed to an alternative because I've had a proper conversation with each patient to actually talk about what it is that's happening. And also that all the alternatives were available on the first consultation that I gave that patient. So as a clinician, my choice wasn't, I'm just going to prescribe Mounjaro. I am going to prescribe the best medicine to help with that patient with the clinical evidence available to me. And at the time when Mounjaro became popular, Mounjaro was the one that had the most clinical evidence of about 22% overall weight loss from the patient if they start. Bearing in mind, we talked about people being on medicine for long term. I would stop that medication if I thought a patient wasn't actually losing weight. Yeah. So there are criteria. If the patient doesn't lose 5% of their weight within 3 months, as a clinician, I should not be prescribing that medication. That doesn't mean then automatically I prescribe them the next dose up because it's not working. And we had an issue globally where a large proportion of patients were on the highest dose of Mounjaro. That doesn't clinically make sense because it takes 6 months for you to reach that highest dose. And that journey should have been monitored. I have maybe, out of all of my patients, 5 patients that are actually on the highest dose. And the only reason they're on that dose is because they have metabolic reasons to be there. They're not responding. these hikes or increases in prices have directly impacted the highest doses. So if anything, it should improve. And I'm not endorsing the increase in price, but it should make the clinician think, hang on, if 50% of my cohort of patients are on the highest dose, what am I doing wrong in terms of how am I prescribing to them? So I would say we cannot prescribe a like for like. We should also make sure that there's a flush out period. We need to make sure patients have the correct information with regards to how to go about doing that. And actually, that choice of alternative medicines should not be based on price. It should be based on clinical needs. And if a patient is making that choice out of price, then we should be looking at what else we can do to help those patients anyway.
Thank you. Thank you. Back to you, Chair.
Thank you. Assembly Member Wilson.
Thank you. The questions I wanted to ask have been covered quite a bit already, but there's a sort of follow-up that I'd like to ask. So I was going to ask about the risks of inappropriate use of these medicines. So, the right medicine, but being used for people who shouldn't necessarily be on it because they're not actually overweight, they're not obese. But also the risks of these sort of unlicensed suppliers and potentially, therefore, fake or unlicensed or unproven medicines. But just for the sake of, to sort of confirm for clarity, what are the actual kind of consequences or symptoms or other conditions that they might then present with further down the line if they're either using the right product wrongly or the wrong products in the first place? I think you've mentioned pancreatitis, but there are other examples of symptoms that could come forward.
So a patient, if they are inappropriately prescribed, the gastrointestinal side effects can be quite profound. So there's vomiting, diarrhea, constipation, bloating, nausea. Then there is the malabsorption of vitamins. So you have patients that are fatigued, they are malnourished, and that can really happen if the speed with which they're being prescribed is too fast. If that patient is being incrementally increased without monitoring, they could reach the highest dose within 6 months. And if their appetite is suppressed and they're not being nourished, then you've got a problem. So if a patient comes to me and said, I don't eat anymore, that's it, I'm having a proper conversation. You should be eating, and the food you have should be nutritionally dense. And that's, as a clinician's hat on, that I don't want my patient to stop eating, because that's not the point of this medication. It's also a part about education. What are the right foods you should be eating? Health literacy is sometimes the main reason the patients got into that position in the first place. They don't know what good food is. What is food? Just simple anecdotal examples of teaching a patient, if your great-grandmother doesn't recognise the ingredients that you're putting in your mouth, it's probably likely that it's not a good thing to eat. Whereas we've educated ourselves to think that, that's the thing to just go and pick up off the shelves. It's trying to plant the seeds educationally about what is a nutritional diet. It's not a diet, it's actually eating appropriately. And perhaps we could get to a stage where these medications aren't the sole use, they're a catalyst to getting us there. A lot of my cohorts, they're not even on the highest dose. They're not even on the middle dose. They've been sitting on the lowest dose for 6 months, 12 months, and they're gradually losing weight. And it's not just because of the drug, it's because I'm talking to them about other things that they should be doing. So I think it's really important. Education is really important. And from wherever they can get the right education, that's really key.
I was just going to come into that. So you had two questions. So one was the risk of the kind of fakes, which I actually can't comment on. I don't know if you've experienced that. I guess if you don't know what you're injecting, the risk of that is anything, right? The second question was the right product, but they were not overweight. Was that your question? Yeah. I think the problem is that when somebody's taking this medication, it's reducing their appetite if it's working quite significantly, which means that you're not necessarily going to be having 3 meals a day. They might not be balanced. You run the risk of then some people might pick or might graze throughout the day. They're not actually having nutritional foods. One of my biggest concerns actually is something that we're seeing, which is not necessarily the right product but not overweight. It could also be somebody who's overweight, is a rise in this really niche type of eating disorder, which we actually haven't seen before. So people are, I said at the start, they're sort of excited by the lack of appetite. So in the NHS, I might be seeing a patient who's eligible for a weight management service, They're taking the medication privately, and then they're being seen by me, and I'm saying, you're not eating enough, and you're not eating enough protein. You run the risk of shredding your muscle mass, nutritional deficiencies. I'm going to need you to eat a little bit more. And when then that is met with fear and panic and confusion and sadness, that's when you've actually got quite sort of disordered eating and potentially eating disorder category. So people are kind of using the medication, and this is not all at all, but there are pockets that are appearing of people using the medication to bypass the hunger, to lose significant amounts of weight, and actually then that ends up entering into this sort of really new eating disorder category, which won't ever fit into an eating disorder service and doesn't necessarily fit into any diagnosis we have already. The only thing I could liken it to is there's a condition called diabulimia, which is where you basically abuse insulin if you are type 1 diabetic, and then you run with high blood sugars. It's not the same at all as this, but it's the only thing I can kind of compare to where somebody is misusing a medication in the interest of losing weight to a point that it puts their health at risk. And this is people living with obesity and overweight and also healthy weight. So that would be all of those categories. So, but we have seen patients like this in our weight management services in the NHS. And obviously their weight at that point is not underweight, and therefore it doesn't get picked up we'll pick it up, our psychologists will pick it up, but it doesn't sit in a category just yet. And it is a concern of dietitians and psychologists, particularly because we do a lot of these kind of the follow-up appointments and the wraparound care.
Sorry, I've got a tickle in my cough, so excuse me if it kicks off again. It's just to highlight around the illicit medicines and patients obtaining medicines that are counterfeit, possibly. And I guess it's impossible to say what those risks might be, just as Joanna outlined, and they could be potentially life-threatening depending on what is in whatever they've obtained. I won't call it a medicine, but the GPHC has released a guide on how patients and the public can ensure that they're buying medicine safely. And that's been endorsed by a number of regulators. So we have got that guide. And we've also released a statement on ensuring on how to check that pharmacies are registered as well. So we have those two things to help and help support the public. And again, some education for the patients and the public on how to ensure those things would be helpful. And then just touching on the points around people getting the medicines that are not helpful to that are obese but not using them properly. And again, this is probably not from a regulatory perspective. And what Suki was saying around patients not getting to the 15 milligram stage is probably something. There's probably something to consider around what healthy weight loss actually looks like. And I think there is, and tell me if I'm wrong, because you both are have more expertise than I do. Like 0.5 kilos to a kilo is around per week is around a healthy weight loss. And so where patients are probably losing 2, 3, 4 kilos in a week, that probably should be signalling to a provider that they don't need to be going up to the next increment, and probably staying where they are. Am I right in saying that? Yeah.
Yeah, I think personalization is really key here. Every individual is different, and they need to go through a different journey. Continuous clinical checks so that you pause or discontinue treatment are really important as well. But also we should be able to now start helping people understand body composition better. We have some pretty crude tools right now, like BMI, which can be... BMI is good enough in many ways, but body composition and understanding where and how and why you're losing weight and how you can stay strong and healthy through the right muscle mass, the right bone density, really important. How we make that accessible to everybody, I don't think we're quite there yet, but we are getting there. In terms of illicit access, I think we really underestimate the problem and misunderstand it. The other day I was sent by somebody a link to a Chinese website where you can buy retatrutide. Retatrutide is a drug that is in development by Lilly, and it could be the next generation of anti-obesity medication. And you can buy active ingredients as somebody that does research somebody that develops, I don't know, specific products in a clinical setting. However, people are finding these companies and are buying directly and are importing ingredients that are designed for clinical research and injecting them in their bodies, which I find mind-blowing. And we should be, and I don't know if the Assembly would have different access to information around that. I'd love to see statistics on some of those products and how their import levels has changed over the years, because they should be pointing towards the level of misuse and abuse that is happening. And then they should also be pointing towards where enforcement needs to take place. But I think this is, counterfeit medication has always been a problem. Illegal providers, online providers continue to be a problem. But I think now we're starting to see a very different, another level of sophistication, both on the people that provide these products when they shouldn't, but also an audience that is searching for those, which wouldn't have been the case even 5 years ago.
Sorry. That example that you're giving, I had literally a photograph from a patient with a box full of fake medicines, including the one that's in a phase 3 clinical trial that shouldn't be even available. And this patient told me that their personal trainer openly showed them the box full of this medication from a Swiss lab. So the packaging, everything is, it doesn't even look like the medication, but it's being sold as generic medication. That petrifies me. So I'm fortunate that patient recognises what's good and what's bad. But what about the patients that don't know that? That's our biggest problem. How do we empower our Londoners and our general public to know that that's not the route to go by? You know, that's our biggest hurdle, because it is available, because they can go to their online providers that are registered or their local pharmacy that can provide it. But why are they not doing that? Why are they still going, and why do they still think it's okay to go to their salon, to go on an Instagram site and go on a TikTok site? Why is that still acceptable in the psyche of our population? I think that's our biggest question and our biggest dilemma of how do we educate our patients to not take that risk.
Sorry, I know we've touched on the price hikes already, but it's just to add that the price hikes are probably going, you know, they might contribute to people seeking illicit sources as well, and using, you know, the phase 3 trial medication as well. But the other thing that we've, the GPHC have seen is the use of social media to teach patients how to extract something that's called the golden dose. And the golden dose is a tiny bit of medication that's left at the tip of the pen, which is there to help calibrate it, am I right? And people are being taught how to extract that dose. Now, that brings about, you know, a lot of other risks and concerns as well around, you know, how is that being extracted? Is it the right needle being used to then administer the medicine? Is it the right dose? And it's just, yeah, just a whole picture of problems that then kind of lead to you know, patients getting medicines in the wrong way. So yes, the illicit sources might, you know, lead to might be increased usage of that because of the price hikes, but also we might see people then cracking their pens open to get that extra dose as well.
Yeah. Thanks. The golden dose, is that like just the extra bit, or it's a more concentrated amount? Is that?
It's a pen has 4 doses for 4 weeks, but it has almost the equivalent of a dose at the end of the pen.
Right.
Now, when the patient has done 4 doses, if they try to do the 5th dose to try and get access to that, the pen locks, so they can't get access to that. So there are WhatsApp groups and Facebook sites that are encouraging patients to buy needles and extract it through the other end and pull out that last dose. Now, there are 2 problems with that. The pen is only eligible for 30 days. After that point, it doesn't classify as being sterile, and it's not clinically safe. It won't have the stability. So you are moving into week 5. So then you are injecting something that may be inactive and may also carry infection. And then you've got a patient not putting the correct dose into themselves and administering it via needle. So you've got so many fear factors and risks that are there, and that could have been pushed, but that was happening before the price spikes. Then you've also got patients that are administering 1 week, not administering the next, and they're trying to extend their doses over a 2-month period. Well, then they've got a whole 28 days of where they've got a drug that's not valid, and they think that they've done a really good job. And that's lack of education and lack of understanding. But then how do you police that? I can only police that by trying to educate every single patient. But you have got online influencers who are giving those ideas to patients. They're actually encouraging that behaviour. And how do you police that? That's a really big worry as well.
Thank you. Assemblymember Harani.
Thank you, Chair. I just want to, following Joanna's point, just ask about eating disorders and sort of the new category you mentioned, because that's a topic actually the committee has looked at in the past. And for those that are maybe accessing these drugs either online or other countries, do you or have you found people coming back to you, maybe yourselves in the pharmacists, just to say that their problems around eating disorders have gotten worse as a result?
So I can only speak from the NHS, and actually we're seeing that people who are experiencing binge-like eating are actually finding that their symptoms are actually getting better, but only while they're on the medication. And again, we don't know what's going to happen when they come off the medication. The really specific type of eating disorder that we're seeing, which has not got a name, it's more just clinicians working in the field seeing it. I can't even give it a name or a category, but I've only seen a couple in the NHS because they're obviously living with obesity and eligible for a weight management service, so I'm then seeing them. So actually I think that I don't know whether you're seeing this in pharmacy, but anyone who has any signs of disordered eating in our MDT service is going to be under the psychology team members anyway. They're monitoring that. But the really specific piece there, I don't know if you have been seeing this in pharmacy at all. Yeah, do you want to speak to that?
I was going to say, when we are prescribing, we should be looking out for eating disorders before we prescribe anyway. That's part of our criteria. But if something develops, that will develop through the journey and we'll see it happening. And then it means that we need to either stop and we need to refer, or what I'm finding is those that are accessing it from an illegal site are then coming to me to be fixed, a bit like coming to the NHS to be fixed. And then that process is also difficult because then I need to try and manage what's happening and try and identify what's happening. And you're right, Joe, sometimes it doesn't have a name, but it has a behavioural pattern that we can see. And it's sometimes reaching a maximum dose and then being cut off from that dose. And then the behaviour comes back. This medication works on those cravings and those food noises that are sometimes part of masking a already pre-existing food disorder, an eating disorder. So it's as a clinician, having your clinical hat on and being able to identify those things. Nobody should be stopped off of this medication cold turkey. So those patients that reach their optimum or their goal, and it can be any type of goal, doesn't necessarily have to be a weight goal. Like we spoke about earlier, I have patients that their goal is just to be able to walk more. They want to be able to have their knee operation. Or I have one patient has lost 24 kilos who was waiting for a atrial fibrillation cardiovascular appointment in the NHS. She was not safe to have that operation until she lost weight. Now she's lost it. She's higher up in the waiting list because she's now eligible to have that vascular, that operation. That wouldn't have happened if I hadn't intervened and coached her through that process. But that took a year. She wouldn't have been able to do that herself. And these disorders can be picked up by clinicians and they can be sort of fed into the system. They may have not been seen before, but that there is a way of sort of, we need to sort of sweep them up somehow and give it a name, I suppose.
Give it a name. I just wanted to add that in the NHS, we do a lot of screening for patients at the start before even going to consider giving the medication. So medical screening, psychological screening, we give them a lot of advice. The patient I mentioned just then is somebody who got it privately, who then ends up in our service. I think that's really important to kind of create that line. Like, we would never have given this lady the medication at that point. So either they have, disordered eating before they start taking the medication, or an eating disorder, or it can then develop through the use of it. And that's something that in the NHS we would pick up because they're in the MDT. And again, privately, it depends on whether they are, who's prescribing and what that wraparound care looks like.
Yeah, I'm just trying to think of, so if you had an individual, let's say, who has a recognised eating disorder, but then separately to their appointments or the system that they're in there, is then accessing these medications, it shouldn't happen.
They shouldn't be getting it.
No, it shouldn't happen, but if someone's just
Then
searched online
that's
and
that grey
got
area
it,
that we're trying to fight against. A
But would
proper
there be-
prescriber wouldn't.
but would there be somewhere within the system where the person who's managing the care for the eating disorder is then just regularly checking in, or has it on their radar that a patient might have found a way to get drugs which they shouldn't have access to?
So diagnosed eating disorders should be seen at specialist eating disorder services, and the waiting list for those, and I won't comment too much on it today.
Yes, yeah.
The waiting list for those are through the roof, and actually we see in our weight management services, sometimes somebody has, for example, binge eating disorder diagnosed, we want to refer them there, and that waiting list might be massive, for example. So the ones we see in weight management services are mostly binge eating disorder and bulimia, but this really niche category that's kind of slowly kind of pocketing up, as I said before, is specifically related to these medications. So if somebody's in the NHS clinic and getting this medication privately, and then I see them, I refer them to our psychologist for an MDT discussion to see how we can best support them. But we can't take that medication away from them because they didn't get it from us, right? So when I'm then giving diet advice how to take the medication safely, that's then causing distress in that individual. And this is just one, and where I work, we're seeing sort of 2,000, 3,000, 4,000 patients per year. That's this slowly just sort of coming up, and I think it's a conversation we need to have with eating disorder services, because this doesn't have a name, but it's sort of this grey area somewhere in between that's sort of emerging using these medications.
I was going to say, with just my community pharmacist hat on, we're really skilled at picking up on patients that are vulnerable to eating disorders, because before any of these medications came out, we're already screening patients that continuously come back for laxatives or something, and so we won't serve them, or we'll identify them and we'll signpost them. So there is an element of, we have that knowledge base of picking up on cues that sort of recognise that that patient might be vulnerable to an eating disorder. So it does give you an insight anyway, as a clinician, what you're looking for. I can't describe exactly what it is, but I'm a bit old in the tooth. I've been a pharmacist for 28 years. I sort of got used to knowing what kind of behaviours those patients will present. Yeah. But as a good prescriber, they shouldn't be getting access to that.
Yeah. No.
Sorry, I'm just going to have to unfortunately come in. So we've run out of time on the session today. So perhaps if you want to come in really briefly on this, and the final question, perhaps Krupesh will have to ask for that in writing.
No, it was just to say that, because your question was around whether people that need to know, so the specialist dietetic services, find out whether someone with an eating disorder has obtained this medication in a private way. And I guess in an ideal world, that is where we would want to get to. And from an online perspective and a private perspective, we would expect, the GPHC would expect, that there is an appropriate communication happening with the person's general practitioner or their regular prescriber. However, I think we've also got to acknowledge, like, the long waiting lists and GPs being burdened with, a lot of other work and important work streams, that information might not be getting to where it needs to in a timely way. So I think my point is that I would welcome, and I'm sure the team, the panel would welcome, like, proper, like, collaborative working across the system.
Okay. Thank you. Thank you. In the interest of time, so I've got two questions that I think I'd appreciate written answers on after this session. So one is specifically on the pharmaceutical industry, because there's a tendency when new drugs or products come out that additional support is given at the beginning just to, well, obviously there's an interest to make sure that it's working properly and can be expanded further. So I would like to know what support is being provided by the manufacturers of the drugs to yourselves as well. And the last question, which was on our list, was just what further action you'd like to see to increase access to weight loss medicines and address any risks associated with them, which I think most of you have answered before, so it's sort of a catch-all. So if you have something that you want to get off your chest at this session that you haven't been able to, then please send that in. Thank you.
Thank you. On that last one, it's really quite the focus of this. So if there is anything you do think needs to be done as soon as possible, if there's anything that any of you could say in a sentence, then we do have time for that. If it's going to be longer, then do write to us. So,
Grey area, we need to target those hairdressers, those Instagram sites. Is there something that the police can do to start? It's a bit like the vaping problem. Illegal vaping, we've got the same level of disparity with the weight loss medication. We think it's 1.5 million that's registered that we know, but we don't know how many are actually accessing it illegally, and that worries me. If there's something we can do within our London area for the people, is get rid of those.
Thanks. Anybody else? Really
I'd say
briefly.
better access to safe sharing of data through different partners. Pilot to try an approach that combines different disciplines or shares insight from different providers with each other.
Okay, really well. With that, and please do write to us further with any further evidence and the answers to those questions. With that, can I thank you all so much for joining us today. We're really, really pleased to have your expertise on this area as we go through this investigation. We have a further meeting in a couple of months' time in which we'll do our second session before bringing together the recommendations and evidence from this. So thank you so much for that. Can we note the report on today's discussion?
Noted.
Can we also delegate authority to me as chair in consultation with group lead members to agree any output from the discussion?
Agreed.
Brilliant. And just for the guests, we've just got a couple more items. If you want to start packing up, you can. It's going to be very brief. The Health Committee work programme. Can we note the committee's work programme?
Noted.
The date of the next meeting will be the 26th of November, 10 o'clock in the chamber. And I have no urgent business, so I therefore declare this meeting to be closed.
This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by. This is the broadcast from City Hall, the home of the Greater London Authority. Please stand by.